neurodevelopmental delay among a certain subgroup of children with birth asphyxia, and also children with who are born premature. So one of the things we're really looking forward to is looking for adopting interventions. Yeah, and our prayer is that we'll be able to adopt some of the interventions talked about here in Uganda. Thank you so much.
Thank you very much, Dr. David, for the amazing work. As we are here to advance the evidence-based interventions for mental health, thank you so much for taking us through postpartum depression, which show that it's real, and showing us the association between of it with early childhood neurodevelopmental delay. And with that amazing work, we're going to come back after with such questions, specifically with the exploratory analysis that you did with other factors that might lead to neurodevelopmental delay. Dear audience, kindly note questions, and we have a specific time for our speakers to ask more about their work. Now, we're going to have Miss Grace Musabyimana, who works for Save the Children International, and she's going to take us through an interesting work that she did. With her bio, to begin with, Grace holds an advanced diploma in mental health and a bachelor's degree in public health. She's currently working with the Save Children International as a mental health and psychological support specialist in the mental health department, especially in managing mental health conditions. Now, this is what is special with Grace. She has initiated occupational therapy interventions in Mahama refugee camp, and will be scaling up occupational therapy interventions in other camps across the country. Right now, Grace is going to take us through the impact of occupational therapy program among refugees with chronic mental health conditions. Grace, welcome.
To address these challenges, Save the Children put in place mental health and psychosocial support services, including chemotherapy, psychotherapy, and occupational therapy activities for their community reintegration. Save the Children supported 351 patients with mental health-related issues. 40 patients with stable mental health conditions were enrolled in the occupational therapy program. As a result, 37 of 40 people with stable mental health conditions successfully completed the occupational therapy program. The program helped patients improve their mental health and their livelihood conditions.
Habyize mu mwaka umwe byahise bihwana. Rero biradufasha ko twarabaye inshuti, twaramenyanye ku buryo umuntu abazi no ku rugo gundi. Ubu turagenda no mwibaraba tukagenderana, ukabona natwe twishimye turabana.
Mu bigaragara ndahamya pe ubufasha yankoreye bwagize icyo bunkorera bumfasha muri jewe.
Ubu sinabura isabune, ntago nabura njya mu nzu z'abana, nk'ubigarama rigiye kure. Ndikora hanyene arangurira impuzu akanangurira n'ibyo harabona igisha harabaza bakambaza ati mbe uratwigisha ntego tariko nta buryo dufise ati cara ngaho wige nta kibazo nankamufashe nkuko nanjye bamfashije.
Thank you. This was the video that could demonstrate the testimonies from the patients. And let's jump to the conclusion. The findings shows that mental health occupational therapy serves as a valuable approach to promote well-being, resilience among refugee individuals residing in refugee camp. By incorporating a client-centered and culturally sensitive approach, occupational therapy intervention can help individuals to regain a sense of purpose, rebuild their life, and develop the necessary coping skills to navigate to the challenge they face in the camp setting. This occupational therapy program indicated improved mental health skills development, income generation, a sense of empowerment and camaraderie, and a hopeful outlook for the future among the participating mental health patients. This highlights the effectiveness of mental health programs in promoting holistic well-being and fostering a supportive community. Thank you. This is our presentation.
Thank you so much, Grace, for the amazing work that you're doing at Save the Children. And indeed, as I told you, this is what we're here for. There's kind of evidence-based interventions that has such impacts on mental health of people. So for more information, we have a lot of stands in the room, and there is Save the Children stand right here. I think it's the first stand when you pass this side. So during break time, after lunch, you can pass by and know more about the amazing work that Save the Children is doing. Thank you so much for the amazing work, Grace. Now, as we move on to the next presenter, and this is Molly, MC Grain. Yes. Molly is a Master's of Social Work student at the Boston College School of Social Work. She's specializing in global and macro practice. She's also in her last year at the Boston College Lynn School of Education and Human Development for her bachelor's degree in applied psychology and human development with a focus area in organizational studies and human capital and minors in restorative and transformational justice. Molly has been conducting independent research on familial dysfunction since 2019. When she had her TEDx talk on the value of dysfunction. And today, we are lucky to have her, and she's going to tell us about defining and quantifying familial dysfunction. Welcome, Molly, and we're ready for your amazing presentation.
Hi, everyone. Good morning. I'm so excited to be here today. I'm here to talk to you about how we define and quantify familial dysfunction. So during this presentation, I am going to review a brief background of how this terminology came about in research, where the research stands today, and my recommendations for where we should go moving forward as we study familial dysfunction. So, in the context of social work and social sciences, familial dysfunction has been studied for over 60 years. Dysfunction is a term specific to sociology, first appeared in 1949, and it was completely separate from the idea of existing in a family system. We first saw discussion of what a dysfunctional family might be in the late 70s and early 80s in the US in the context of refining family therapy and what that may look like. And then in 1995, the ACEs survey, or the Adverse Childhood Experience Survey, created its own loose working definition in order to attempt to measure it within a larger context of adverse childhood experiences. What's important about this definition is that they said that a dysfunctional family was one in which children were exposed to substance abuse, mental illness, their parents' separation or divorce, or anyone who was aware of specifically their mother being physically hurt in the home or having an incarcerated family member at some point before they turned 18. What's significant about this working definition is that it's extremely limited, and it doesn't necessarily align with the research that we have today, showing that most physical, sexual, and emotional abuse of children occurs from their own family members and within the home. And this also wasn't entirely aligned with the research that had already been done. And we hope that when we build definitions, we stand on the shoulders of the research that existed, and that's not necessarily what happened with our first loose definition in 1995. So these graphs are from Google Books, and it's just to highlight that around 2013, we've started to see a sharp decline in the use of a dysfunctional family, and even just the word dysfunction in general, as we're describing research, and there's a couple of reasons for that potential dip. These are some of the measurements that we have used to quantify familial dysfunction over the years. And I've bolded some of the language used in them just to emphasize that currently there is no continuity of language used, and the only way you would know that all of these measurements have a connection in regards to measuring familial functionality is if you looked at them all individually, which is not a great place to be in as researchers. And this goes back, again, you can see on the slide to 1970. Two of these that we're going to go into a little bit more in depth about are the ACEs Childhood Experience Survey and the Behavioral Risk Factor Surveillance System, which is adapted from ACEs and used by the CDC in the US. Okay, so looking at the ACEs, or the Adverse Childhood Experience Survey, it's a yes or no questionnaire that was developed using a group of predominantly middle-aged white men in Southern California between 1995 to 1997. It was funded by an American insurance company, and their original data set to this day has not been released to the public. Yet, despite this, it's been widely adapted, used all over the world. It's been examined for many different kinds of research, especially mental health and physical health, widely regarded by the CDC, cited in hundreds of different academic journals over the years, and it's kind of considered this unofficial gold standard for how we measure familial dysfunction. But again, we don't even have access to the original data set that it produced. And when it is adapted internationally, we sometimes use the ACE IQ specifically because it was recognized how much we were using it all over the world. And it's already been shown by multiple researchers who have analyzed this work that it does not accurately reflect global concerns, and it has a lot of Western bias. So we're not properly studying working children, forced economic migration, famine, or even neglect. In the original 10 questions, there were no questions about neglect at all. And so we have this really difficult situation where we're rooting a lot of our current international research, making the same mistakes that we've been making for 50 years. So when I came into Boston College as a freshman, I had all these ideas for the research that I wanted to do regarding familial dysfunction. And my first study that I submitted to the Institutional Review Board was a specific study on children who had experienced substance abuse in the home. And I called my list of studies the Dysfunction Series. And this is some of the feedback that I received from the Institutional Review Board regarding that. Sorry, one moment, I'm waiting for the slide to load. In short, what I was told by the Institutional Review Board is that they strongly suggested that I remove the word dysfunctional due to its stigmatization, and that the word dysfunctional stigmatized conditions, and that instead I should use words like trauma, suffering, or resilience. And that was really important for me to hear, because it made me take a step back and really consider what other words and diction we were using when we do this research on family functionality. So diction is very important, and trauma, suffering, resilience, and family dysfunction all mean very different things. And the most important differences are that a family is a unit, it's collective, whereas most of the time that we talk about trauma, suffering, and resilience, we're focusing in on the individual being affected. And a familial if a family is not functioning properly, that doesn't necessarily mean that there's suffering or harm being done, because it's possible that that individual is getting the support they would need from a functional family system elsewhere, in school, in mentorship, through other people. But when we use words like trauma, suffering, and resilience, we are inserting the assumption that harm has been done and that it needs to be recovered from. So what we're doing in the very early stages of this research, unfortunately, are reframing. We're putting unnecessary onus on an individual, and we're almost adding in this bias of what are you going to do to overcome what you've experienced, when they haven't necessarily faced a family that would set them up for failure in the future. So the concerns of these current measurements, aside from this unnecessary responsibility that we place on individuals is also, our overemphasis of Western values and cultural norms, a multiplication of this error over time. And the most important thing that I want you to focus on this presentation is this last bullet point. Sorry, one moment. So sorry, bear with me. The most important thing that I want to emphasize is that we are constantly conflating three separate scenarios when we measure dysfunction today, which is what happened to an individual, how that individual responded, and who that individual has or will become, which are three very separate things. So today we see a lot of measurements that ask, were you neglected as a child, and do you abuse substances now? And the problem with measurements that stick the past, the present, and the future together is that it doesn't take into consideration genetic component, it doesn't take into consideration personality, it doesn't take into consideration what they've experienced outside of the home. And so when we conflate these different things, that is part of the reason that we're coming up with research that isn't as accurate as it could be. So again, that last bullet point on conflation, that is my primary concern when I am researching this. Okay, so if we can get ourselves back to the table, that's the hope. I might have to jump around a little bit, I apologize for that. Sorry about that. Thanks for bearing with us. So my research looks like this. It's pages and pages of data points and analysis where I look at the title of the test, the keywords, the key themes from the abstract, the country that they're used in, and where they're adapted from. And time again, I've seen adaptions from English survey-based items that go back to ACEs or rooted in other less than ideal measurements for familial dysfunction being used all around the world with different language than family functionality. So for my research currently, I'm only looking at the measurements that we've used in 2023 and where those are coming from. And the hope is to be able to draw a list where we can look at where it's rooted in and where it stemmed from and working on correcting some of the errors that we have made. So my recommendations moving forward are that we solidify a working definition of dysfunction and that we use it appropriately. And this definition could be as vague as circumstances that could have negatively impacted long-term functioning of household members. And what's important about this definition is could have and also members plural. So say we have an individual who's being abused outside of the home environment. That might not affect the functioning of other household members, but say it's an older sibling that comes home and repeats this pattern of abuse on their younger siblings, now we have something that is relevant to a family system. And the hope is that using a definition like this that is malleable and current research can be applied to will allow us to create a standardized method of measuring family functionality that's rooted in current research and cultural assumptions as opposed to things from 50 or 60 years ago that no longer apply to what we understand about family systems, and that our results will be able to change based on regional beliefs surrounding what a family's function even is, because most of this research does not ask the key question of what do you think the role of family is in your life. So it's important to recognize the limitations in any research. The limitations in mine are that I'm using a very small sample. I'm only looking at the studies that have been completed in 2023, and the thoroughness of my article review. I'm only looking at the title and the abstract to get an overall sense of themes, and ideally we would see a more complex literature review regarding the specific questions in all of these measurements being used. And the reason for these limitations is that I'm at the very beginning of this research. I study in the School of Social Work, but am graduating with my bachelor's in May, so although I've been analyzing this research under the advisement then of a couple doctors, Dr. Stephanie Skopolidis and Dr. Julia Devoy at Boston College. Right now, this year, I'm standing kind of independently with this research, and so my hope is that I can meet more of you, and that we'll be able to reach out and connect and talk about the future of this research, the future of psychometric research in general. I'm really, really hoping to get to meet all of you today. Thank you so much for being here and for emphasizing how important familial research is. And thank you again to everyone who put this conference together. It's so exciting to be here and to meet you all. Thank you.
Thank you very much, Molly, for the amazing work. And I think we should expect the presentation of the results in the next research symposium, all right? Dear House at Large, as I said, keep on noting important questions as we're going to have a specific time for Q&A session. Now we're going to have our last presenter before we move to the panel discussion and Q&A session. And this is Associate Professor Zefon Lister. He's an Associate Professor in Counseling and Family Sciences. He's the Director in the Department of Counseling and Family Sciences at Loma Linda University. Prof. Zefon holds a PhD degree in Marriage and Family Therapy, MS in Marriage and Family Therapy, MA in Religion that he got from Andrews University 2001. And he specialized in various areas, including couples and chronic illnesses, medical family therapy, religion and family functioning, and a lot more. So we're going to have him today for his presentation on his work that he did about using a task-shifting family and school-based intervention to improve emotional regulation and family functioning among parents and children in Sierra Leone. Prof, we're so excited for the presentation, and thank you for being here today.
Good morning. I'm glad to be able to be here. We had several travel challenges coming here. I got a chance to spend extended time in Turkey, but I'm glad to be able to be here today. I'm going to be sharing a little bit, and this is a great lead-in from a previous presentation, thank you very much, on looking at a task-shifting strategy for addressing emotional regulation and family functioning. And we'll be looking at a pilot project that we've been doing in Sierra Leone, but with implications for many low and middle income countries. Sierra Leone is in West Africa, and as a country in West Africa, and with a population of about 8 million people. It has 16 districts, 5 regions, largely Muslim, and it's been facing several challenges since the early 90s with civil war. Yeah, the Ebola challenge back in the 2014, 2016, floods in 2017, and then most recently dealing with COVID as the whole world did within the last few years. Additionally, there's additional daily stressors around poverty and also around education, as well as challenging living conditions. So we've talked about family dysfunction, and while the definitions are definitely broad, there's one of the questions is, one thing that we have found is that family dysfunction is connected to poor social and emotional development, mental illness, and behavioral problems in children. And then also we know that children who are raised in families that also have parents dealing with poor mental health also are connected to other issues such as family violence, hurtful parent-child interactions, and also negative child outcomes. And so as we look at Sierra Leone, with some of these challenges, one of the things that we start to look at is, well, how might we be able to address some of these challenges? we've talked about in our plenary some of the challenges facing mental health overall within low and middle income countries. This is just reflecting of those things in terms of the infrastructure for mental health services. Currently, based on most recent data, there's less than 10 psychiatrists that are functioning for individuals who have severe mental illness. Psychiatric nurses are on the increase, but still significantly lower than what we would desire for individuals within that region. In terms of psychologists and mental health professionals, again, there's a dearth of individuals who are available to provide mental health services. And so then there's the question of how do we address mental health within this context? And so while we wait for the slides to progress, one of the things that we started to ask, and this is part of the driver for this project, was as we talked about when we talked with our collaborators, we initially started back in 2016, right after the Ebola crisis. We worked with the Waterloo Hospital of Sierra Leone to come and do some training for them within the community resiliency model, with the goal of helping to support the stress that came as a result of navigating the Ebola crisis. Once we did this training, we trained about 40 individuals. Those 40 individuals who got trained reached back out to Loma Linda and said the benefits they had experienced from the project were of a nature that really said, could you teach us to teach others? And so initially when we sent over our trauma team, the goal was this is to support the well-being and resiliency of this population. But we started to think, could this actually be used as a potential task shifting strategy? And so we went back and actually trained this group of individuals. Of the 40, 22 asked to be advancedly trained. And so they were trained and then went out and trained about 800 community members in the community resiliency model. From that area, the results that we got from that pilot project, the results for depression and anxiety and post-traumatic stress, mirrored those of us professionals who went over and did the same intervention. And so we started to get excited about that. And so we continued to talk until the next question is, well, how can we really start to expand this in a much more sustainable way? And so we looked for interventions that were feasible, scalable, culturally adaptable. We needed personnel, as we talked about, there's the limited personnel and infrastructure for mental health. And so how do we kind of leverage what was available? And so we talked about what institutions or what infrastructures are currently present within the community that we might be able to use. And so we looked at hospitals, but then most people who go to hospitals and clinics are individuals who are sick. And so then therefore we said, well, we don't want to be reactionary, we want to actually be proactive. And so what might be another option? And so we did discuss churches. And so in discussing churches, we said, well, that's good, but again, within those populations can sometimes be very isolating to their respective congregations and their specific communities. And so we started to ask the question, could we actually utilize schools as an infrastructure, utilize schools as a setting to actually disseminate some of these skills? And so in looking at this study, we wanted to address the high prevalence of mental illness, family violence, family dysfunction. We wanted to examine the limited resources to respond to mental health needs. We wanted to look at the inadequate infrastructure available to address mental health and family functioning. And so we needed to find effectiveness. So we wanted to evaluate the effectiveness of a family and school-based intervention, low-dose intervention, utilizing community health workers trained in this particular approach in order to implement this intervention. And we wanted to determine, one, whether or not non-specialist behavioral health workers could be used to implement this intervention, Could we use schools to actually be the environment where this intervention could be actually implemented, as well as looking at whether or not this improves the support of family functioning and mental health. So this is just a really quick picture of our team on the top right-hand side, and then below is just some of the trainings within one of the schools and with some of the parents as part of that intervention. So the design was, we looked at, if we were going to want to engage these individuals, we realized that we wanted to look at teachers, we wanted to look at parents, and we wanted to use at children, meaning, we know that if you just work with children without addressing the family or the home environment, that the changes seem to be less lasting. And additionally, because we're using a school context, we wanted to support teachers and really helping them understand what we were doing. And so what we did was provide a 12-hour just orientation to teachers. So it really wasn't an intervention to them, it was just an orientation to the intervention. But we did teach them some basics around the community resiliency model, as well as the facet, which is our adaptation of the community resiliency model. We also looked at working with the parents, with schools. We looked at one school that received only the community resiliency model intervention, and then we had 2 schools that we called CRIM Plus, or facet, that integrated some family functioning specifics. The community resiliency model is an evidence-based, evidence-informed model developed by Elaine Miller from the Trauma Resiliency Institute that really focuses on 6 basic skills and uses a bottom-up approach, meaning it really focuses on the use of recognizing interoception and self-regulation. Interoception is simply, as opposed to kind of traditional therapies, and maybe like cognitive behavioral therapy, where you start with the thoughts and how they affect emotions, so forth and so on. It actually comes from the bottom up, where you actually first looking at the sensation of mood, sensation of well-being, and then really focusing and working on those sensations within the nervous system. How do we actually biologically help to regulate the nervous system as a way of evoking change? These are the 4 concepts of the CRIM model and the 6 skills that they use. The facet program that we created included or added family communication, behavioral management and discipline, problem solving, and then family boundaries and adaptability. And so was the CRIM Plus, was what we called our facet program. These are all the different measures that we had with teachers, parents, and children. Today we'll just be focusing on the highlighted ones, which was looking at resilience, these are not, there's some challenges with the formatting, but we really focused on, it should be highlighted, the emotional functioning. So emotional regulation is what we looked at using the DERS, and then we looked at using the FACES for family functioning. Very quickly, we'll talk about our findings. So I'm just gonna these are just some of our demographics here. On the left-hand, on the left-hand side, you're gonna see kind of the facet intervention. So in terms of understanding the graph, on the left-hand side is the facet intervention, on the right-hand side is the CRIM intervention. And then each of those colored lines are time points. So baseline, and then right after the intervention, and then 3 months after the intervention. One of the things that we must consider, for better or worse, was we actually did this just before COVID. So we actually did our baseline. Before we knew about COVID, we actually did our first post-test 1 right after the intervention, 2 days before the school shut down for COVID in Sierra Leone. And then we did our 3 months, literally 2 weeks after the government reopened for socialization. So there's definitely some confounding factors that we have to consider as part of the results. Very briefly, just looking at it, what we found was that there was a significant effect found for the FACET program in improving emotional regulation. We saw similar findings among children as well. For family functioning, we didn't find any statistical changes or effects for family cohesion, but for the FACET program, we did see some significant changes in family flexibility or family adaptability. For family communication, we did see significant improvement from both the CRIM group and then also our FACET group. Additionally, we also saw that there really wasn't an overall improvement in areas of family satisfaction. This was largely due to overall families reported feeling fairly satisfied. So going into it, they reported feeling fairly satisfied, and so there wasn't necessarily a significant changes in those areas. For children, for their family functioning, there was significant improvement reported by both the CRIM-only group as well as the FACET intervention in the areas of family functioning with flexibility as well as cohesion. So for the children, we did see improvements in both their perceptions of flexibility and cohesion within the families. Similarly, for family communication and family satisfaction, we did see their perceived improvement in both of those areas as well. In short, our findings suggest, and again, these are just preliminary findings, suggest that although improvements were found for both the CRIM and FACET programs, meaning the CRIM-only intervention and this addition of family communication, parent discipline and boundaries training, that there were stronger outcomes for the FACET intervention as compared to the CRIM-only intervention. For parents, findings were mixed on the effectiveness of each of the program family functioning domains. So neither program found significant improvement in family cohesion or overall satisfaction, but that is largely due to families reporting feeling close and feeling satisfied with their families overall at the beginning of the intervention. However, we did see some significant improvement in flexibility or adaptability, as well as improvement in communication for both programs. For kids, consistently across all domains, we saw improvement of perceptions around family functioning, as well as emotional regulation. We weren't able to get into the weeds, but if you saw any of the lines kind of crossing back over on the graphs there was some regression during time 2, either during time 2 or time 3. Again, in trying to maybe understand what's going on, may indicate the need for a booster. So again, this was kind of a brief intervention, so there may be a need for a booster session, or there may be some confounding effects of having to do this study during a pandemic when schools were being shut down and being opened up. So we still need to kind of replicate what we're wanting to do. We're wanting to kind of explore a couple of different ways of maybe adapting this model further to further increase the ability to disseminate these skills. Few limitations, of course, there was a low parent sample, and as I'm running to the finish line here. One of the things that we found was when we talked with our collaborators and we asked about literacy, they said they're good, and then when we got there, they weren't. And so we ended up losing actually quite a bit of our sample initially due to literacy issues that were assumed. And so that is definitely a big lessons learned. And so that we did with our parents in particular, did lose some of our sample as related to that. Not sure of the influence of COVID, and then of course methodological limitations of convenient sampling. Some of the strengths, we not only got data from parents and children, but teachers. We haven't analyzed the dyadic data yet when we're actually matching parents with their child and looking at some of these outcomes. So we're in the process of doing that now. We were able to examine the effectiveness of the model in an unintentional naturalistic design with high stress, and saw that even though it was doing a high stress event, we did still see some significant improvements within this approach, which was encouraging. Of course, the use of quasi-experimental design, being able to compare two groups, and then what we're most excited, being able to use local resources, personnel, and infrastructure. So that's really what we're wanting to build on, and hopefully we're able to move towards, using this pilot data to apply for some, maybe NIH, NIMH funding. A conclusion, both the CRIM and FACET models were found to be effective low-dose interventions, improving emotional regulation and family functioning. Non-specialist health workers can be effective resources for scaling up service capacity in under-resourced environments. And then schools may be able to play a critical role in under-resourced settings with limited mental health infrastructure for the dissemination of mental health education and intervention. Thank you very much.
Thank you so much, Prof. Zifon, for the amazing work that you did in Sierra Leone. Now, we're moving to the session of discussion of all the presentations that have just passed. And I keep the order as we presented. And I dedicate my first question to Dr. David. Thank you so much for the amazing work you did in Northern Uganda. And if there is something I saw in your presentation, as I said, postpartum depression is real, since you say that 1 of 5 mothers have it. And I think that is what encouraged you to assess its association with early childhood neurodevelopmental delay. And your results showed no association, and you did an exploratory analysis to find other associations that might lead to neurodevelopmental delay. And since your results were promising in showing the neurodevelopmental delay, I'd like to ask you if the mother's postpartum depression is not as impactful as other socioeconomic factors that you mentioned that might affect or have impact on neurodevelopmental delay, what do you see as being the key areas of intervention for health workers and policymakers to support children with neurodevelopmental delay in northern Uganda?
Thank you so much for that question. Maybe I'll start by saying that, of course, one of the things we learn from this conference is the importance of having a composite intervention, an intervention that is holistic, like the Sugiria Mulango. You'll forgive my pronunciation. And one of the things that we have seen is the importance of the socio-economic status, the importance of the feeding, the importance of the simulation. And from where we see things, it's like many of those, most of our participants are depressed, have postpartum depression. Currently, we are doing a bigger study of around 6,000 mothers, where we have looked at postpartum depression in detail. And one thing that comes out is, though so many women are depressed even in the antenatal period to the postpartum period, but from around 8 weeks going on, the prevalence goes down. So if we are looking at neurodevelopment at 2 years, many of these women would have become better, and these other stressors of life, like the absence of stimulation, poor feeding, the economic status they are in, could be playing a bigger role. Yeah, so one of the things we take away from this conference is adopting these holistic interventions like Sugiria Mlango. Thank you.
Thank you so much, Dr. David. And this is what all policymakers should be doing, adopting such interventions that have direct impacts on such problems we're facing today, including neurodevelopmental delay. Thank you so much. I'll dedicate my second question to Grace, since you were the second presenter. Can you have the microphone, please? Yes, thank you so much for taking us through the very amazing work that Save the Children did with people who have mental health problems in Mahama refugee camp. And I like the way you started highlighting the burden of having a mental health problem and being in a refugee camp at the same time. But again, I liked how your results about the impact of such occupational therapy programs in people with mental health programs have been so impactful. Where I say that among 51 stable patients that you dealt with, 92.5% completed the whole program, and 100% self-reported and increased self-esteem. I would love a round of applause for that, which is something really good. And I'd like to ask Grace for this amazing work that you did with Mahama refugee camp. Can you tell us more about the inclusion and exclusion criteria for these occupational therapy groups that you took? And please go ahead and tell us if you are planning to expand this program to more refugee camps that we have in Rwanda.
Thank you for a good question. It's amazing. If I start by the impact, as I said in the presentation, 47% out of 51% has a remarkable increase and increased self-esteem. And these have been measured by the fact that these 47, they are the one who has completed the 1-year full program. And the four other one, they are continued with other session. As I presented that, this activity is cascading 1 year to another one. And it's the group who have been coached, who is coaching the new sessions. So these 4 ones, they have some challenge, some limitation to continue the program. Some went out of the camp, so then they dismissed the program. Some has also lost the out with some other challenges with like family issues, and they have reported 100% of the good implication of this occupational program, because we have also approached this fourth one who didn't finish the program, but they have reported that they had self-esteem which is increased. They had no other community stigmatization has decreased. Even if they didn't finish the program, but they had at least the good importance and the good reputation from the short term that they gained this program. And we are planning to cascade this program to other refugee camps, as we are operating in all camps, refugee camps in Rwanda and transit centers. And I have had a remarkable impact of this activity. I wish to cascade this activity to other patients in other camps so that we can decrease these relapses in mental health patients. The criteria, there is no exclusion or inclusion, but we are based on patients who had experiencing most relapse than others. As I said, this patient has mental health conditions which are chronic, and we have seen that they are mostly relapsing even though they were following their treatments. So the reason why we decided to add other activities so that they can improve their well-being. We could have like 3 relapses in 1 year to 1 patient. The reason why we concluded that we can add some other intervention so that we can reduce this relapse, so that we can also help this patient to regain their self-esteem, their community reintegration. Thank you.
Grace, my last question you didn't come with. Do you plan to expand this amazing work in other refugee camps? Like, we have other refugee camps, we have Kijeme, we have camps in Gisagara. Can other people with mental health problems in other refugee camps benefit from this amazing work?
Yeah, for sure, this is a plan which is in our implementation activities. I think Dr. Daniel, who we are working together, can answer this question because he's the one who is programming that plan, so that he can answer more.
Dr. Daniel, can we have an answer for this question?
Thank you. Thank you very much. Yes, I think based on the findings, first of all, we only piloted in Mahama camp because that's where we felt we had a bigger footprint in terms of programming. We also had some approvals to go through from our implementing partners as well as from our donors. As you've noted from the presentation, it's more of a holistic approach that included occupational therapy, mental health, and looking at the outcome. We hope to cascade this in possibly other 3 camps. That's Nyabiheche, Kigeme, and Kiziba. However, there are issues that we need to go through. So possibly the next presentation or in the next research symposium will present possibly that we are able to cascade this to other camps. But true, that is part of our program. Thank you.
Thank you so much, Save the Children. So I think we can expect some more amazing work to be done in more refugee camps. Thank you so much, Grace, and the team from Save the Children. And you can please pass the microphone to Molly as I ask her my question. Thank you so much, Molly, for the amazing work that you are doing, that you're still doing with family dysfunctioning. And I would like to ask you, you discussed that suffering is kind of individual and family dysfunctioning. And you talked about how definitions would likely change the context of someone's research. And I remember among the recommendations and comments you got from the Institutional Review Board is about the word dysfunction itself, how it could be sometimes stigmatizing. So I would like to ask you, Ms. Molly, how should clinicians and researchers consider different cultural definitions within their work in order to keep the context and not deviating from the actual work that they want to do and the results that they want?
That's a great question, thank you. So one of the things I looked at was going back with just like the etymology, like where did we get that word from? Is the mic on? Yes, maybe. Sorry, thank you. And it goes back to Greek, and one of the definitions of dysfunction that I think we don't give a lot of onus to is that it can be translated to just mean imperfect. And of course, everybody's family system is imperfect. You couldn't possibly have a perfect family, especially if you have multiple children. They all need different things. And so my hope is that moving forward, when we adapt measurements for international use, that we can encourage clinicians to, when they're explaining what they're studying, and to also communicate that when we're looking at the functionality of a family, what matters is, what do you want from your family and what matters to you, but also just that there is no perfect family, there is no perfect functioning family, and that any definition that does this research should emphasize that the stigmatization around this idea that some families are better than others is really, really harmful. And one of the reasons the CDC focuses so much on ACEs is because they have a list out of recommendations, and one of the things that the CDC recommends that we do in this work is to work against the stigmatization of this word. And so I think that by using it more instead of less, we might be able to follow CDC recommended guidelines and work against the stigmatization of this word, just to say that all families are imperfect and all families can be improved, and that's what we want to focus on moving forward.
Thank you so much, Molly. And if you could please pass the microphone to Prof. Zefan. Prof, thank you so much for the awesome work that you also have been working with family functioning among parents and children in Sierra Leone. I would like to ask you, you discussed the methodological challenges of this study that you conducted in Sierra Leone. What are the plans for future trials? And how do you plan to address the issues of illiteracy in future data collection?
Great questions. So we set up the intervention where, of course, we oriented the teachers, and then we did it was a 5-week intervention where we met 1 hour twice a week with the kids during the last hour of the school, and then we met with the parents 1 hour after school. And so we were able to demonstrate how kind of using non-specialists could actually implement this intervention. But as we're thinking about kind of future ways to kind of expand this approach, this intervention in the future, we've started to think about the idea of, as opposed to just using community non-specialists, what if we actually train teachers to actually do the intervention itself? So we actually train teachers to be the non-specialists to actually implement these interventions in their own school. So I think if we did that, we would maybe have even higher buy-in. We would further support teachers. They would not only learn the skills that they can use within their respective classrooms, but then they would also be able to, we'll be able to further expand dissemination as opposed to using one team traveling around to multiple schools. If we actually train teachers within their schools, then we would actually have schools themselves now being the infrastructure to really support parents and children in improving resiliency, supporting family functioning, improving mental health. And then these families go back to their communities, and then they're able to talk to their family members. And so we're hoping that we may be able to even map out at some point some dissemination back into their own communities from the schools. And in terms of the literacy issue, so what we ended up doing inside of the intervention, we had to switch from self-report surveys to interviews. And so we kind of changed midstream to make that adjustment. And that's been working for us so far.
All right, thank you so much, Prof. Thank you so much to every presenter here on the stage. And we've got 15 more minutes open to the audience. We've had amazing presentations, and I'm expecting that you've noted down some questions that you have. So, protocol team, yes, help me distribute the microphones. And can we have 3 questions? Then we answer that, and then if we got more time, then we shall take more. All right, thank you.
Sure, thank you. This was a really terrific panel, and I wanted to ask David a question in particular about childhood stunting, which, as you know, in Rwanda is still at a rate that the government is really trying to solve and bring it down. I don't know what the rate is in Uganda, but I'd be interested in your thoughts on the association between maternal depression and stunting. What do we know? And then what are the implications for both Uganda but also Rwanda, where they're struggling with this issue of, stunting is a broad indicator of underdevelopment. If a child's stunted, it means a lot of other things are not happening well, while the mother's health is underway, as well as once she's pregnant. There's probably stressors and malnutrition in pregnancy. And then in early childhood, you have the issues also of the social determinants of poverty, of stressors. And I'm wondering, for countries that struggle with stunting, like Rwanda, could we layer evidence-based mental health interventions for maternal depression, but also the social determinants pre and during pregnancy, and then for early childhood, interventions like Sugira Muryango that look at not just violence and improving family functioning per the discussion we're having, but also nutrition, hygiene, problem solving, navigating the systems. So I'd just love your thoughts to talk about the implications of your research for stunting and addressing stunting both in Uganda and Rwanda.
Thank you very much. I think I may have millions of questions. This is a very exceptional panel, like the others you are going to have. And yesterday you have very interesting panels. So I'm going to ask one question, but if the time could allow, I will ask a million of questions. The question I want to ask is, David, how this mental health can be part of the antenatal care services delivery and even the postnatal. I'm assuming that what we know about mental health during the prenatal, antenatal, and postnatal, possibly our colleagues in the health are not familiar, and these difficulties remain undiagnosed. And then the decision will be different because our colleagues are not educated or informed. How do you think this can be incorporated, and if it is done in Uganda, in the antenatal care services? And I wish you can also comment on what my colleague, Professor Teresa, said. What is your interpretation about social determinants? How do they really inform the services, and how do they relate to the mental health? Just more comment in terms of interpretation of the prediction and influence of the social determinants. Otherwise, I'll continue asking my questions during the break, but very interesting conversation. Thank you, my colleague, Professor, for what you shared with us, and I hope we can continue the conversation, and others, and many more, and the moderator. Thank you.
Thank you. My question is dedicated to... thank you. My question is dedicated to Molly. The first question is, we know that we have different cultures, and different cultures have different perspectives about trauma, abuse, and resilience, and familial dysfunction. I want to know, during your research, were there any cultural considerations about that? And if there were, what are they? And do they have any impact on that research? And if there is an impact, what's that impact? Thank you.
Great. One more question from behind.
Yes.
Yes.
Thank you very much for all the beautiful presentation. My first question goes to David. Did you look at the parameter of previous perinatal depression? Because that has shown previous perinatal has a higher risk of childhood adversity rather than the ongoing pregnancy. And for Professor, that's good for Sierra Leone, but I want to know the baseline investigation for the mental health status for the parents, because I noticed you didn't have any significant result when you did your project with parents. And for the literacy rates, this is just like an advice now, what normally I think you should think of doing is about involving community with local language, because that's the best way they can understand, and that's the way you can see results. Thank you.
Thank you so much. One last question from Dr. Dieudonné, then we respond to those 5. And if we get more time, we'll have more, and if not, We have break time, we have networking session in the evening. We'll be asking more questions. Yes, one last from that side. Okay.
Thank you very much for a great presentation. My question goes to Molly, who defined the family dysfunctioning, and I want to start with an example of a video that we saw viral in Uganda. They were saying it happened in Uganda, where a family decided to live naturally as God created them. They decided to go naked, walking the streets, as a father, a mother, and daughter. It was their decision. And another example is, for example, if a family decides to use, they say, drugs, and they say everyone at home, after lunch, for example, or after dinner, will be having drugs. Can that be defined as a family dysfunctioning? And is it right if the society or the community decides to put that particular family on what the community on what the community defines as the right behavior or the right functioning of the family? Thank you very much.
Thank you so much, audience, for the participation. Now it's time for the presenters to respond to the questions.
Thank you so much for those very good and thoughtful questions. I'll start with the first question on whether postpartum depression could be associated with stunting. Let me start from here. One of the explanations as to why the postpartum depression may not have had an effect is the nature of the families around in Uganda. We did a study about 4 years ago, and what we found out was in the postpartum period, it was usually the grandparents and the relatives of the mother who are taking care of the child. That means even if the mother would have been depressed, there was a social cushion. There were other people who are engaging the baby, taking care of the baby, and that would go on for the first couple of months, up to maybe 3 months. The mothers would actually come and camp at their daughter's place. But now when it comes to stunting, I think there could be a link because the immediate insurance that these relatives would give, after some time they move away. And now the burden goes back to the mother to take care of this child. So that's an association that I'm actually going to go and look out for. We have the data and we can actually look for it. And also the underlying issues are the same. And maybe I'll say something concerning the second question. So we started another cohort of 6,000 mother-child pairs, and because of these findings of a lot of postpartum depression, we decided to assess antepartum depression, postpartum depression, and give these women care. But about 50% were coming for care using the tool we're using. We're using the EPDS. So the issues are a lot. And when you would investigate further, they had a socio-economical or sort of background to them. It was due to the challenges in the family, the absence of food, the economic hardships during COVID. They manifested as antepartum depression and postpartum depression. So in many of these deprived societies, there's a lot of mixture between maybe the pathological part of it, but also the socio-economic determinants to the problem. Yeah. So in a society where we're having a lot of these issues, I believe we'll also have a lot of depression. And the second speaker asked what we can do about it. One, and he's very right, the postpartum depression is there, but we are not assessing it. So the first thing is to screen for it. There are tools, 10 question tools like the EPDS that anybody could ask. One of the things we are doing right now as a sub-project is to validate it in Uganda, because some of the questions in the local language, they don't make a lot of sense. Yeah, questions about the feelings, questions about, many of the questions we didn't have language for them in our local languages. So we are validating that tool. And that tool can be administered by somebody, even a community health worker, if interpreted. So number one, let's ask the questions. Number two, we asked the questions in these 6,000 mother-child pairs, but we are overwhelmed because we didn't have enough resources to manage all of them. Yeah. So the second part of it is to come up with interventions that have been task-shifted interventions. The primary therapy is cognitive behavior therapy. Can we interpret that into a set of instructions that a community health worker can deliver? In other words, can a community health worker offer some cognitive behavior therapy so that as we are detecting, we also have a mechanism of managing those that we screen positive? So that's what I would sort of say in terms of moving forward with a postpartum depression question. Yeah. Let's screen for it. Let's come up with interventions that can be delivered by community health workers in a task-shifted pattern. Somebody asks whether we assessed for previous peripartum depression, and unfortunately we didn't. We did not assess for previous peripartum depression, and thank you so much for that observation. We shall actually maybe look for it going forward. Yeah, thank you so much.
Yeah, I think, yes, we're good. We're good. Thank you. Thank you for those questions. They were really excellent. Quite a few things came to my mind in terms of cultural influences on dysfunction, and also just, the potential ethical conflict of letting a community decide what is and isn't appropriate behavior, especially as we look at parenting children. One of the studies, and I wish I remembered the name of it now, but it looked at the difference between parental displacement and parental incarceration. So they controlled for children who had to move out of the home with their parents and in with another family member due specifically to incarceration versus just displacement in general. Because a lot of the times children, especially young children, aren't being told that their parent is being incarcerated. So what the study was hoping to look at was, are the developmental problems that we're seeing in children due to parental incarceration due just to displacement, and incarceration is just a piece of that. And that's not what they found. They found that there was significant difference in the development of children when parental incarceration was a factor as opposed to just separation. And so to answer both of those questions with that study, where my brain goes is, even if the specific behavior is debated in terms of whether or not it should be called dysfunctional, the opinions of the community matter, and they affect the way that people respond and people treat children. So even though, the effects might be exactly the same on the child of being in with their parents, if we know that there's stigmatization from a community and from a region about a specific behavior, that then becomes relevant. So when I thought too about different cultural components, you think a lot about sexuality, gender, and just the case of how homosexuality is viewed very differently from around the world. And if you have children being raised by a same-sex marriage, that means something very different in different areas of the world. And there are people who would never want to acknowledge a same-sex marriage and parenthood over children as dysfunctional, because they would say that's not fair. But if there's stigmatization from a community, it becomes relevant. And so the hope, as we look at labeling specific behaviors and the potential ethical dilemmas of letting different communities define what is and isn't ethical, is the good news in that is that if there is stigmatization in a region, that is relevant. And so it should be considered in what we're looking at to define the family. And obviously, you know, our ideas, especially gender roles as well, change over the years. And so the hope, as we're looking at these different regions and how do we define what is ethical and not, some of that risk, I believe, is mitigated when we consider the fact that if anybody considers it to be non-functional or less than, that is probably going to have an impact on the individuals of that family as they navigate the world and the way that they're treated by teachers and adults. So I hope that answered both of those questions.
Thank you for your question. It's very useful to talk about. One of my colleagues is actually, I think, presenting by video, either this afternoon, I believe. And one of the things in looking at some of our baseline data with parents was that family functioning was connected to mental health. So the higher they reported their family functioning, the higher they reported their or less depression, less anxiety, less post-traumatic stress symptoms. However, when we look at our sample as a whole, overall, we were looking at a community sample. And what we know that in generally, families tend to do well, right? And so in our intervention, we weren't necessarily working with a lot of families who were reporting high levels of, perceptions of dysfunction. Actually, most of our families reported feeling pretty good about their level of adaptability, the level of and flexibility, cohesion, communication. So the improvements that we saw in our study were actually from good to better and not from bad to good, right? And so for some of the areas, particularly in the areas of cohesion and overall satisfaction, there was kind of a ceiling effect. They came in feeling really, really positive about how closely they were feeling, their overall satisfaction as a family. And so there, in terms of the intervention, if you saw kind of the time points, they were clustered really, really closer together because there wasn't really a whole lot of, there wasn't a whole lot of room to grow in those areas. So I think in terms of the parent data, that's what we kind of noticed. With children, we did see a little bit more variation. Again, it was still from kind of good to better, right? So again, we're still having kids reporting overall feeling good in their families, that their perception of families functioning well. So that overall they had positive perceptions around their family functioning, but they did report kind of improvement. And I think there's a couple different pieces, right? So, some of the things that, just from a design perspective, you had kids who are now having their parents spending time with them twice a week specifically on them, right? So, so I think, that could definitely have been just a factor of dosage, right? Of actually having more dedicated time with their parents. And so those would be things that we would need to kind of control for in future studies. And then to your second point related to kind of addressing literacy, I think you hit the nail on the head. And one of the things that we were very intentional about was really shifting the entire curriculum that we had to that cultural context. So we spent weeks literally sitting down, going line by line with the intervention to say, how does this fit within this cultural context? Because it's so important that it would be relevant. And then again, even in asking the questions, one of the benefits of having community, someone from the community asking those questions is that they would be able to, if there was a question about the question, they would be able to explain it within that particular cultural context that really made sense to them. And so we spent time really wanting to be careful about how the intervention was really adapted to that cultural context. And I think it was pivotal in terms of its translatability. So, thank you.
Thank you so much for these amazing presentations. Thank you so much. Because yes, I wanted to thank everyone in the house for an active participation. Thank you so much, dear presenters, for the amazing work that you're doing, for everything you presented to everyone in the house. I hope we learned a lot. And I know there are more questions. How many can we admit? 3 more questions. Protocol team, help me to have 3 more questions, straight to the point, and keep it as short as possible. 1, 2, 3. They are already there in the house. Great. Yes, please hand over the microphone to anyone around. All right.
Okay, thank you. My name is Bigirimana Emmanuel. I'm an occupational therapy student in University of Rwanda. So my question will be for Grace. And we normally know that the mission of occupational therapy is to have the client who attend the intervention to receive and be able to regain functional independence in these 3 categories of occupational area: in self-care activities, productive activities, and leisure activities. So I wanted to know about the research you've done, how these categories of occupation are reviewed, especially focusing on productive activities, since we want the society to be productive in socio-economic aspect. Thank you.
Thank you. My name is Ranz Safar. I am a clinical medicine and community health student in University of Rwanda. First of all, I appreciate all the presentations you presented. They are really beautiful. And I would like to ask Grace Musabyimana this question. Which factors would be likely contributing to the mental health problem relapses, particularly despite the occupational therapy coping strategies being implemented? And what do you think would be the gaps? Thank you.
Thank you. I hope I am the last. And my time was limited by doctor. I tried to be brief as possible. It's not the question, it's a recommendation. I would like to reach presenters personally, but I found that it may interest everyone. I would like to recommend our presenters to avail their research reports or resources available and easily accessible for all of us as implementers, as researchers, so that they can be useful for the community members' life improvement. Thank you.
All right. I hope every presenter has a question addressed to him or her, so you can go ahead.
Thank you for the amazing questions. Let me start by the first one. How these activities, how this point of occupational therapy have been implemented. First, for the self-care, as I said, these patients have chronic mental health condition, and you know how those patients in crisis look like in the community. So when we planned for the occupational therapy program, we have to have a safe place for this patient, and they come like 2 times per week. So where we have the education sessions, how they can take care of themselves, the hygiene and whatever. And we also do productive session, and you have saw that in our presentation, this is a productive part. When they are making this shopping bag, they gain income from them. They shop them at the market, and they gain the money so that they can take care of their families, of their children, and then the livelihood conditions are improved. In the racial activities, this patient also not only gain the productive part or self-care education only, but they also play football, they dance, they attend music therapy sessions. So this is the leisure activities that they are gaining. And I can add also if there are some exhibitions, activities that are held in our district, this association, they are also invited to present their activities, so their self-esteem, their self-resilience are increased. If we go to the second session, which are the factors that influencing the routes, as you know, this is a refugee camp, and the refugees have so many stressors. You know, these people have lost their families, they have lost their family members, they have moved from their countries, and they are actually disconnected from what they have been before. So the livelihood conditions have also changed. So when they arrive in the camp, the livelihood condition as they have changed, they need to integrate into the life in the camp. So sometimes with this patient with mental health condition, they are, if I can say, they are lost, they are neglected because this is not a roaming issue as some somatic disease. So if they are not considered as this is a serious issue, they will have so many relapses. There is not enough medicine that they can gain. There is not enough intervention that are looking for mental health programs. So that could be also the factors that could lead to the relapse for them. There are new cases which are seen in the camp, and you have also these refugees who come with mental disorders, and the refugee status can be also a trigger for their relapse. The gap, if we go to the gaps, you know that in the camp the health structures are not well oriented to respond to all intervention that are needed to respond to mental health program. The reason why there are some intervention, there are some drugs who are not available, and they need to be referred to other hospitals or other special cares. So we have listed that factors could be like livelihood condition in the camp and the other stressors they meet when they are fleeing from their countries. Thank you. Is the last one can be repeated, please? It could be better. The third session, the third questions.
It was a recommendation. All right? Okay, to avail the reports for people to access them.
Okay. This is not, I think, a question or other problem. I think we have the link for the presentation so that it can be shared. And I have Libby, I think Libby can help to avail this link with the presentation and the video as well. Thank you.
Thank you very much. dear presenters, for this amazing panel discussion. And House at large, I hope you agree with me that we have been lucky to have experts here on the stage who have proven that with their work, interventions, and research, have proven that collective interventions, collective trust strategies, dissemination of strategic interventions can bring positive changes, specifically in mental health, child development, and parenting, as we are here today to advance these evidence-based interventions. Thank you very much, dear presenters, and I hope we keep connecting. You here, right? Feel free to greet anyone you feel like you want to talk to, and we still have time. We still have one more day with you, so connect, network, and make the best use of these experts and explore whatever you want to explore with them. So thank you very much for the amazing presentation. You can go back to your seats. Thank you so much, both. Dear audience, how are you? Have you slept? I've seen some people dozing. So I think we need some health break. Are you sleeping? Prove me wrong. Stand up. Stand up and I see whether you're not sleeping. Stand up. We're going to stretch a little bit before we go to the next amazing and interesting session. People are not standing up. Are you sleeping? Have you slept? Okay, look at me here. I have a notebook in my hand, and consider that you are this book, okay? You are going to act as this notebook, okay? We go. Stress, 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 stretch. Okay, 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 okay. You are this notebook. Well, let me have one more exercise to check if you're really awake. So, we are going to do like this. This will be boom. This will be snap. And then clap. Okay? Boom, snap, clap. Boom, snap, clap. If I say boom, you know boom. If I say snap, you know snap. And if I say clap, you know clap. Okay? And we are going to see people who are still sleeping. If I say boom and someone does snap, a clap, then you're sleeping, okay? We go. Boom, 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 clap, clap, snap, boom, snap, clap. Some people are sleeping there behind. We go again. Boom, snap, clap. Boom, snap, clap. Snap, clap. Boom, boom, snap, clap. Boom, snap, clap. Clap, 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 snap, 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 snap. Boom, 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 snap, clap. Thank you very much. At least now I'm sure that you're all awake. Thank you so much. I hand over the microphone again to Mr. Joseph to help us go through the next session. Thank you so much for being with me in this session. And welcome, Joseph.
Oh, that was amazing, Mignon. Thank you so much. Shall we give her the flowers? Shh. Thank you so much. So we're going to stretch a bit, walk around, we use the washroom, and then come back in 10 minutes, yeah? 10 maximum. If you come early, that will be great.
everyone can come and take their seats again, we'll go ahead and get started. Okay, while everyone is taking their seats, I will go ahead and introduce the moderator of our roundtable discussion. We will be doing a roundtable on the different aspects of Sujira Muyanga, and this roundtable will be facilitated by Gabriella Fenn, who is staff with Boston College Research Program on Children in Adversity, based here in Kigali. She's the program manager for the expansion study, and we'll welcome her to the stage, and she will introduce all of our panelists.
Okay, hello everyone. Can we make our way back to our seats, please? So this next session is going to be a round table with Sujira Muyanga researchers and implementers. I know we've been saying Sujira Muyanga like a buzzword every 2 seconds. So now you'll be able to hear from the researchers here in Rwanda and implementers actively working on the project. And to bring us back, and we were inspired by Mignon and her amazing energizers, our Sujira Muyanga team is going to lead an energizer to get us back in the mood. So I'm going to invite up Grace, Pacifique, Dieudonné, and Joyous to the stage, and we're gonna do another energizer.
Hello, good morning. So, as you know, or may not know, Tugira Muryango program is a prayerful program. So we are going to be playing. We are dancing, actually. So we would like everyone to stand up. So we need everyone to do what we'll be doing here. If you are dancing, you are dancing. If you are jumping, you are jumping. So I will be singing. Excuse my voice. And first week we'll do the demonstration of what we'll be doing. So my voice is bad, very, very bad, but I'm going to sing. So, Turita, Turita. We'll be singing Turita. We are going to do a demonstration round, and then you will join us. So, Turita, Turita, Turitata. Turita, Turita, Turitata. Thumbs up. Turita, Turita, Turitata. Turita, Turita, Turitata. Elbows back. Turita, Turita, Turitata. Turita, Turita, Turitata. Legs apart. Turita, Turita, Turitata. Turita, Turita. Knees together. Turita, Turita, Turitata. Turita, Turita, Turitata. Okay, now we are doing it. You are singing Turita, Turitata, and you are doing what you are doing. So, here we go. Turita, Turita, Turitata. Turita, Turita, Turitata. Thumbs up. Turita, Turita, Turitata. Turita, Turita, Turitata. Elbows out. Turita, Turita, Turitata. Turita, Turita, Turitata. Legs apart. Turita, Turita, Turitata. Turita, Turita, Turita. You are not singing. Turita, Turita, Turitata. Knees together. Turita, Turita, Turitata. Turita, Turitata. Thank you.
Grace, you have a wonderful voice. So I'm going to introduce this round table a little bit, and I think there's one slide. I don't know how that's being managed. Maybe we can get that one slide. Or not, totally fine. So Sujudo Muryango, as mentioned by Dr. Vincent and Dr. Teresa yesterday, in 2018 to 2019, we had a cluster randomized trial, and we saw so many good benefits immediately after the intervention and 1 year post after. And through that CRT, we expanded in many ways. So one way that we expanded is we expanded the reach of the program. So the CRT was 1,049 households, and we expanded to almost 10,000. And we reached every, as characterized at the time, Ubudehe 1 families with a child 0 to 36 months. So we expanded the intervention really in a significant way. Maybe next slide. Okay. Thank you, Livy. And so we expanded, and we also expanded using a different workforce. We expanded using the Inshuti Muryango. Okay, perfect. Here we go. So you see the CRT, and then you see expansion. So more impact. And we expanded using the Inshuti Muryango workforce, which are the child protection community volunteers under the National Child Development Agency. There are 2 in every village, and we were really lucky to be able to use them to expand And that expansion project brought even more evidence to measure the impact of Sujiro Muryango as delivered by a government workforce. And we saw really, really positive results immediately post, and we're still analyzing 1 year post, but we're very hopeful and excited. And then yesterday, one of the big topics of the day was the longitudinal and spillover study in the middle, which again, Dieudonné and Teresa and Dr. Vincent presented on, and we saw really positive impacts of the program 4 years later after the intervention and despite, the huge shocks of the COVID-19 pandemic. And our last expanded arm was capacity building with University of Rwanda, which you're all participating in now with this research symposium. And basically, we wanted even more impact. So University of Rwanda students, faculty, local researchers gain research and writing skills, as well as grant writing skills. And so this helps us even gain more evidence about the Sujiro Muryango program. So this roundtable has participants from each of these arms, and I'm gonna invite them to introduce themselves. So starting with Grace.
Hello again, I'm Grace Umulisa. I work for Sujiro Muryango program on the side of FXB Rwanda. Maybe I can explain. We are implementing the Sujiro Muryango program in collaboration between FXB Rwanda, University of Rwanda, and the Boston College. So I work for Sujiro Muryango on the side of FXB Rwanda as a gender specialist. And you joined the program in 2020 November. Yeah, I like the program. I'm honored to work on this wonderful program. Thank you so much.
Great, thank you very much. My name is Dieudonné Uwizeye. I work for the University of Rwanda in the Department of Development Studies, and at Sujiro Muryango, I'm a postdoctoral research fellow. And I'm interested in, as I presented yesterday, to follow up the 4 years after the implementation of this program. What are the benefits can we see in our communities? What are the benefits can we see not only on the children that has been the focus of the intervention, but also the other children in the family, like the young children, that is the children that were born after the intervention, and the children that were there that were adults, because actually the program selected children who were 0 to 36 months. So my interest in seeing now the children that were now above that age limit, how did they benefit from the interventions? So that's what I'm doing with the
Good morning, everyone. I'm Pacific Wamahoro. I work for Sujiro Muryango on FXB side as a program research advisor in the expansion phase. My role mainly contributes to the quality improvements through training the staff, volunteers on data management cycle. And together with the University of Rwanda, I'm contributing to the development of the digital dashboard. It's a locally hosted data management tool. So in collaboration with the university, we are developing that and have been tested through the expansion phase to be able to capture and get real-time data and feedback. Thank you.
Thank you. My name is Joyeuse Ukwishaka. I'm a medical doctor. I'm a pediatrician by training. So I find myself in a Sujiro Muryango in the capacity building arm. So Achieve program is a consortium of 10 universities, 4 in the US and 6 in Sub-Saharan Africa. And University of Rwanda is one of the Sub-Saharan African universities in the Achieve. So it's a 1-year mentored training the trainees are embedded in research in implementation science and data science. And they achieve training and intend to equip the trainees in research so that they become independent researchers. So during this year of training, I'll be having mentors. I have my mentors here, Dr. Teresa and Dr. Vincent, and I'll be researching on the effect of single caregivers household on the responsiveness to community intervention, taking the case of Sugira Muryango. Thank you.
Hello. Okay, great. I realized I also need to introduce my Judah Mnyongo on the side of Boston College. But I work in Rwanda 100% of the time. I'm based at the FXB office, and I work closely with the University of Rwanda. So this is my team. And so for this session, we know that yesterday there wasn't a lot of time for a Q&A for the longitudinal and spillover results, and we've also been saying Sujuda Mnyongo a lot over and over, and so we want this session to be super discussion based. And so any questions you have, please write them down. I'm going to ask one question to each participant, and then I'm hoping for a lot of audience engagement. So all those questions you had yesterday or today about the Sujuda Mnyongo program, either the research or the implementation or the capacity building efforts, please ask away. And so my first question, I think oftentimes in implementation and in research, we want to show the really positive side, the positive results that we're seeing. But it's also important to show the things and to talk about the things that we didn't see and what we're going to do to address it. So my question is there any evidence that we're not seeing that we wanted to see, and how are we going to adapt Sujuda Mnyongo forward to make it an even more impactful program?
Yeah, thank you, Gabi. Maybe I can start open the discussion. We have seen amazing findings throughout the program implementation and research, but we have missed some. For example, the IPV reduction, intimate partner violence reduction, is one of the findings we didn't see in our findings. There may be a lot of things that lead to not having those results. For example, some data were collected after the COVID pandemic, and you know very well how the pandemic was, the lockdown, and we think that maybe the lockdown has generated a lot of stress that leads to the IPV in household that may hinder the good work we had done, and yeah, COVID may be one of the reasons. And another thing is that you know our cultural social norms. We do have this gender inequality, and yeah, it is in all of us, including the Inshuti Muryango that we have used. It rise to deliver the sessions, the Sugira Muryango sessions. They were trained. We did the capacity building, but you know that mindset and this cultural thing that to get the change is a long journey. Even if you had the training, even if you had the continuous training with the ISOs, they still have this cultural norms bounding them that cannot lead them to work very, very well on supporting the families in the IPV reduction. And even the families, teaching them guiding them on how they should reduce the IPV issues in their homes. It's not an easy, like, you can't have that immediate results. So we have thought about how we should address this issue, how we should address the issue of IPV and IPV reduction. And we are trying to review our training manuals. ISUs needs more trainings to get to understand the IPV issues and the way of supporting families and the roadmap to the service providers. So we will continue the training, the capacity building of Inshuti z'Umuryango so that they can support families. We are reviewing our training manuals. We are planning to review our curriculum so that each module has IPV and gender messages so that we can emphasize on the IPV reduction and gender promotion and gender equality to each module of the program. So we have so many plans to overcome this problem, and we hope to see more findings around the IPV reduction.
Thank you, Grace. It's so important that, you know, in research, make adaptations to learn from the findings and make programs even better. So thank you, Grace, for highlighting some of the key adaptations that we'll be making for the program going forward. My next question is for Dieudonné. Yesterday, in the longitudinal and spillover presentation, we focused a lot on the quantitative findings. And I know, Dieudonné, you've been working on the qualitative findings. I'm just curious to know, what are some of those key qualitative findings that you're seeing? Are there any stories or quotes that are particularly surprising or interesting?
Thank you very much. Quantitative. It is very interesting. It is very interesting. Those who are purely quantitative, I would like to call you, to bring this call to you, that reading people's minds is very interesting, and what the qualitative studies do. It is about what people think. So what we saw is that in the qualitative, people are strongly describing the experience they have had with Sugira Muryango interventions. Remember, this data were collected just last year, and that was 4 years after the intervention, but they're still telling you, this program helped me a lot. Like, some of them, they described that they were very poor, and no wonder when this program was recruiting people, it was focusing on people from Ubudehe 1 and 2. So some of them are saying, now I'm no longer poor. Now I'm having my own cow, I have my own domestic animals, I have renovated my house. And this is because of the knowledge I got from Sugira Muryango interventions. They told me that I can build on the capacity I have, and now they have built their own capacity based on what they have learned from these interventions. Some of them have even moved from where they were living before, and then they came near the road, where they can now see the beauty of development. So they are saying, we are very happy now. If I want to go to Kigali, I just take a car here. So these are some of the experiences they have had with Sugira Muryango. So they describe it, and when you see them describing it, you see that it's actually coming from their own heart. And this shows that this intervention that goes at the household level and build from the household capacity and experiences can last for a long time and can leave a very strong signature in people's minds. Something else that we are seeing in the qualitative data is that the knowledge of the people have improved, and therefore it has affected their practices, and also their attitudes has changed. For example, I can mention some of the aspects of knowledge that has improved. For example, the child discipline. Before, they would tell you, if a child has made a mistake, I would have my own stick at the corner, and I always beat my child because he has made a mistake. But now, because of Sugira Muryango, my behavior has changed, and I know that beating a child is not going to help the child. I rather need to bring the child together with me. We discuss the grounds, and we agree on how to behave properly. So when they are describing that changes that happened in their knowledge, you see actually that intervention that goes at the household level is really awesome and very important. And also the way they resolve their conflicts. They say, well, we had conflicts before and we used to fight with my wife or my husband, but now when they're about to come a conflict, we have learned from Sugira Muryango that we sit together, we discuss, we agree on the sources of the conflict and why this conflict is coming to us and how to resolve it. So their knowledge in conflict, in household conflict resolution has improved, and you see it describing it. Also, the caregivers' engagement. Fathers who are in the room here are now, I think we have demonstrated how some of the activities that fathers are taught to do. So they go home now today, they have changed their behavior, they go home and they start now playing with their kids. They dance with their kids, they help their kids to make their own toys at home. And this is a practice when they're describing it from their own hearts, you say it, that is something that is there to last. Also, we are seeing in the qualitative data that there have been changes not only in disciplining a child, not only in engagement in caregiving, but also in child nutrition. Parents are describing that they make sure that they have vegetables at home. They make sure that they have a small fish that we call in our language indagara. They make sure that indagara at the home, small fish, because they know the benefits of feeding the child properly, that is going to help the child grow properly, grow cognitively, and be able to attend schools and perform well. Also, we are seeing in data that people are aware of treating their water that they use at home. They make sure that the water they use is clean, like for example, drinking water is boiled and is stored in a clean utensil. So they're making sure that this is there, and we're seeing it in the qualitative studies. And remember, I told you that the qualitative studies actually describes what people have in their head, in their hearts. So when we are reading it in the qualitative data, we see that actually changes happened due to this program. And when they're describing the reasons for change, most of them they are attributing this to their participation into Sugira Muryango program interventions. And of course, some of them say when we are in the evening parents meetings, we share with our community members. So we are also transmitting this knowledge to other people in the community. So when we see this in the qualitative data, we actually see that this program is making an impact not only in the families that has been selected, but also in the families that were not selected. Another thing that I can mention is the navigating resources, how they make resources at home. Well, some of them are working for or support, what we call VUP in Kinyarwanda, because remember, as I told you, these families were selected from Ubudehe 1 and 2, but also they are doing some small businesses. We saw especially people from Rubavu district. They were describing how they are going to Goma. You know how that border is very busy. Some of these families that were in the category 1 and 2, they are now engaged in making some money in small businesses or even cross-border businesses. And that shows the changes that happened at household level. Something that also we saw in the data is how COVID-19 has impacted our families, even in the rural areas. People from towns, as we are here in Suits, you might think that COVID-19 impacted us because in Kigali, we had to go to market to get something to eat. And remember, during COVID-19 pandemic, cultural activities were allowed, they were going to the field. And maybe you think that this is not impacting the rural families. We are reading in data that actually COVID-19 has made a very significant impact in their families because they were not able to sell their agricultural products because remember markets were not working. And if they have money, if they have worked for somebody or they have worked in VUP and they have some money, they wouldn't go to the market and buy anything because markets were closed. And remember, these are families which are generally socioeconomically not stable, so they had to eat from the market or from their friends because they have to buy something. So now COVID-19 has impacted their way of living. It has impacted their way of accessing resources, and this has been very significant. So as we move forward, as we think of strengthening our families or strengthening our communities, we need to consider that aspect of COVID-19 because it has made a significant impact in their lives. So thank you very much.
Thank you, Dianone. You know, highlighting what participants are saying about their experiences. And that actually brings me to the next question I have, and I'm glad that you brought up the importance of mixed method research by using quantitative and qualitative data. And my question is for Pacifique, but Dieudonné, if you want to respond, you can as well. And basically, yesterday we talked about the bridge between policy and research, but what about the gap between quantitative and qualitative data? How can we do research that gives importance to both types of research in the same way, not in the sense of, oh, qualitative data will fill in the gaps, but how do we make sure that qualitative data is given the same importance as the quantitative data? And I'd like to ask Pacifique, because you're working at the intersection of this, of implementation, being at FXB Rwanda, but also being the research associate and working on the data day to day. And so how can we elevate participants' voices, both in research and in implementation?
Normally, when we do research, we have our predetermined theory of change. We have our gold standard measurement. So we do research following those measures. But out there in the community, like during the program implementation, we come across other success stories. We come across different realities. So sometimes we may miss some outcomes in research findings, but that doesn't mean we don't have other good stories behind in the community. So what we can do is to get informed on new research questions. So not only stick on the existing proposals or measures we have come with, but we need to open our eyes around and come up with new research questions that should be studied and published. But again, we need to put out those success stories from the beneficiaries. They are quite good testimonies, as Dr. Dieudonné said, which are not yet published. People are like giving their evolution thanks to the program. So we need to put all those findings out. And also we have like unexpected outcomes that resulted from the program. For example, Sugira Muryango didn't expect to have more kitchen gardens built in the homes. But as we move through the intervention, beneficiaries are aware of importance of good nutrition, and they come up with their homemade solutions. So we need to collect all those data and publish them and highlight the positive impact of the program, not only scientifically in the research, but also in program implementation. Thank you.
Yeah, I would like I have been talking about this IPV reduction and not having these findings. You can understand that we really need to consider also these success stories from the families, because even if we don't have IPV findings in our reports, in our findings, when you go to the field, when you hear from the participants of the program, when you hear from the leaders from the district where we work, where Sugira Muryango is implemented, Sugira Muryango program is championed to be the program that supported the district to reduce the IPV, the violence in the household. So we really need to consider both scientific findings and these participant stories, because they can complement each other to get very, very good findings. Because when we have our findings, our reports, we don't have these results. When you go to the field, readers are very, very proud of the program because it supported them to reduce the violence in the home. So I wanted to complement and to show you that both the qualitative and quantitative needs to go together. Thank you so much.
Yeah. When you go to the field, they are set. You can't change them. They are very set. They are there. But when you are going to the field for qualitative data, you only go with guiding questions. The real questions or the answers are within the people. That's the beauty of mixed methods. So it brings, the qualitative brings the voice of the people on the numbers you have. For example, you are saying that the IPV have reduced, they say, by 5 points. But now, what are the people saying about that reduction? Are these women or men experiencing that reduction? That's what the qualitative is going to help you to describe. Otherwise, if you just go with the numbers, sometimes you've used a questionnaire that you have used from somewhere else. I remember my colleague from Uganda saying that they have used a tool that needs to be adapted. So sometimes we're using a tool that has been validated elsewhere, not in the people. And then you are bringing data which are structured on that particular questionnaire that I have used and is lacking the voice of the people. So the qualitative or the interviews or the discussions we are having with the people or the observations we are making in that particular environment is now giving you further information to have a clear understanding of the community you are studying. Thank you very much.
Thank you. And my last question is for Joyous. This program builds up your ability to conduct research on family strengthening, mental health, and child development programs.
So thank you. Call it achieve opportunity. So it's an opportunity because it equips new researchers with skills to become independent researchers. So when I say again about achieve, few details about achieve. So it welcomes the early career researchers from the Sub-Saharan Africa and US, and they are embedded in research focusing on implementation science, especially for the Sub-Saharan trainees, Sub-Saharan Africa trainees. They spend few months in US where they are paired with the expert researchers and expert person, the data science and implementation science, so that they are equipped with advanced research methodology from the design to the implementations. And for the US trainees, they spend at least 10 months in Sub-Saharan Africa so that they become familiar with the contextual factors where the researches are being implemented. So talking about the Achieve, it equips researchers with necessary skills to become independent researchers. Taking my case, I will be using the data from Sugira Muryango, and during this year of training, I will be doing this research, which is funded by Achieve and Sugira Muryango again, and I will be gaining those skills that are equipping me to become an independent researchers. I talked a little about my team, my mentors team. So I have a great team and we have great plans. At the end of training, the trainees are expected to publish their work. So the work that trainees have been doing or working on during the year of training, you have to publish the evidence from this research. But again, beyond publishing, also especially for postdoc fellow, they have to be equipped with skills that allow them to write this big research grant. It can start with the early career research grant or advanced career research grant, depending on the level where the trainee was at the start or at the end of the training. But from my side, I'm just a junior researcher, and I just started with the Achieve a few months ago, but I have already tested what Achieve is giving, and I hope that at the end of the training, I'll be even more equipped. So I hope to write a K43 research grant at the end of my training. So I have to build evidence from what I'm doing. I say that I'm researching on the effect of single caregivers on the responsiveness to community intervention, taking the case of Sugira Muryango. During my analysis, I will try to do the subcategorization of the single caregivers, taking into consideration the age, teens, adult, those who responded more compared to those who responded less to Sugira Muryango. I will try to dig more and try to find more evidence on the single caregivers and how they respond to Sugira Muryango, and the hope to build a community intervention from my findings. So that's my goal at the end of my training. Thank you.
Great. Thank you, Joyous. That's really exciting. I know that we're running out of time somehow, so any questions from the audience? Awesome. We have a big hand raised over here. Hand raised over here, here. Maybe we can take 5 questions. 5?
Okay, thank you very much for the very nice presentation. I'm Kalangwa Diogene. I come from the Institute for Community-Based Social Therapy. I just, let me lay a foundation to my question to really be short. Just in June, I was in South Sudan, and I attended an event where the group that had attended a psychosocial program was graduating. And one woman was demonstrating how she changed or how the program changed her. So she just came and she was having people walking on her knees. I think you can understand what it means, walking on the knees. Kujenda pfukamye. So then it really challenged me a lot because I said, okay, so on my point of view, that was not really a change that I was expecting. But for her, she said, okay, so this program has really helped me a lot. It changed and helped me to regain what I had lost. So then I was really challenged. I said, okay, so who am I to really determine the change for this lady or for this community? In line with that, I would like to know what you do when you are determining the change, or when you are working on the theory of change in your studies? So how do you work on that? So who defines that change? How do we interpret that? How much do we engage the community itself in determination of that kind of change or the theory of change? Thank you very much.
Who should I pick, Gabi?
Thank you so much. This is David from Uganda. I have some very brief questions. My first question, yesterday I noticed that the effect 4 years later was much smaller than the effect after 1 year. And I wanted you to talk a little bit into that. Was it because of COVID, or does the intervention went off with time? Because the early child programs help these ones who didn't go through Sugira Muriango. Could you just kindly talk through, about that? The second is concerning the cost. Could you give us an idea of the cost effectiveness? What was the cost of an entire session of training, and the cost effectiveness to it? And thirdly, I would want to do this in Uganda. And if I was to replicate it, what are some of the key modules that you think would be more effective if I wanted to reduce this? And are the modules available? Is it copyrighted, or can we find it somewhere for those who want to borrow from our siblings in Rwanda? Thank you so much.
Can I say? Thank you. I'm Fred from National Rehabilitation Service. First of all, I want to commend Sujiro Muryango, what they presented to us yesterday. When you reflect on the impact, it is incredible. Maybe I want to know about the hiccups, the challenges. Is there any challenge that Sujira Umuryango, according to the research, that you realized possibly the challenges could have limited the desired impact? You could tell us maybe those who could be having similar approach could learn from the challenges you could have realized. Then number two is about ownership and sustainability. According to the qualitative data, how did you assess that? Any ownership and sustainability, because I'm trying to think where this program is not there, is no longer there. How are we going to sustain the achievements, the impact? Did you look at that and how it is going to be sustainable? I mean, the impact and ownership. Then the last point is about scaling up. What's the plan? Are you planning to scale it up to other areas? Maybe you could share with us the plan ahead. Thank you.
Thank you so much. My name is Samuel Habimana. I'm from Rwanda Resilience and the Ground Organization as well. I'm a PhD student at the Lomalinda University. Thank you so much for Sugira Muryango. I have been reading more and even involving with some activities, benefiting from those for like writing from Sugira Muryango, which is very, very fascinating and impacting the younger researchers to have such experience and being able to be able to be independent in conducting different researches. So my question is about implementing the research. I have been hearing about how in your implementation there is even some results you have which you were not even expecting when you are implementing the program. For instance, building a Karima Kijikon, as Dr. Dieudonné, yes, have been mentioning. With my recent publication on the stunting, as even Teresa Bentancourt has been saying, even the stunting, the malnutrition is a problem which is even impacting the child development. In my research, I have been seeing that in Western province, there is a problem of the sex difference, where the male, the boys, they didn't, within maybe the expectations, how in Rwandan culture we train we expect from the boy, we think his courage is strong and things like that. That's for the DHS data shows that the boys are stunting, have malnourished than the girls. When you are implementing, when you are in household, do you notice that, or it's, yeah, that's my question. Otherwise, thank you so much for a really great program that is impacting our Rwandan community. Thank you.
Thank you so much for the presentation. My name is Christine Mushashi. I'm from Sesidar. My question has two aspects. The first one is about sampling for your research. As Sugira Mulyango is implementing in the families, so I was a bit concerned about the single-parent families, if they are included or not, because we have many. And the second one was about if you plan for the extension, which can be like a study also, about like a comparative study. I know that Sugira Mulyango is implementing in the rural district, if I can say. Is there any plan to implement it or to try it in urban districts? So, and to see also if it can be effective as it is in some rural district. Thank you.
Great, thank you. So I'm going to try to answer a few questions. And David from Uganda, I think we have a longer conversation waiting for us at a break. But I'll answer some of your questions, including adaptations. So currently, Sugira Mulyango, we also refer to it as FSI, so Family Strengthening Intervention. We're currently adapting it in Colombia in South America. And actually, two of our team members from Colombia came here to observe some of our trainings and do some home visits. And we had those exact conversations. What modules are relevant in Colombia, which are not, especially around nutrition. Nutrition's a huge issue in Rwanda. It's not in Colombia. Could we combine that with a health module? We had those exact same questions. And we're also adapting it in the US with refugees. And we also had that question around family narrative, because the first module is, you know, you're supposed to talk about strengths, weaknesses, what are the challenges that you've faced, but what happens when you do that with refugees where the trauma was a few months ago? That could be incredibly traumatic and even detrimental to the program, where we kind of unlock things that maybe home visitors can't address. And so how do you navigate a family narrative module where the trauma is so recent, or how do you adapt to a community, for example, that doesn't need nutrition modules but needs something else? So we're going through that exact process, and we'd be happy to discuss what that would mean to do FSI in Uganda, and obviously create a name that means something. And the other question that you had, I had a good answer and I can't remember the other question. The cost analysis, it's a work in progress. Hello? Okay. It's a work in progress, and that's something that we're going to explore in the next year, because what we want to do is embed Sugira Mulyango more into government structures. So using the EZU structure, so instead of using FXB staff, for example, at the sector level, we would use EZU cell cell and sector coordinators, which obviously has huge cost implications. So we've done cost analysis in the past, but this one that we're doing next year is going to be the most informative because that's our scale-up strategy. And in terms in scale-up, that's what we're trying to do. We've seen that the intervention works in 3 districts, and we've embedded it in 3 districts. We've reached every single family within our criteria, our eligibility criteria, and we see the need and demand for more. So ideally, the goal would be to scale to all 30 districts in Rwanda, including urban settings. And we did this kind of on a small scale because we worked in Gisenyi town. And so that was kind of a test of, when we're working in more of a town, and that's like a transit city between Goma and Gisenyi, how does that differ from some of the other more rural areas? And so we're exploring that too as we scale up. But that's the goal, scale up to all 30 districts and use that IZU community volunteer structure and use the child protection welfare officers at the district level and have a clear exit strategy for FXB to move to another district. And so we're really trying to get district ownership and district buy-in so that when FXB leaves, the IZU structure is so set up that they're able to maintain the intervention over and over and over. So that's the goal. And I believe I will move to my other colleagues to answer some of the other questions.
So there is a question from Alfred about the sustainability. As Gabi mentioned, we work with the Inshuti z'Umuryango. It's a community-based workforce. So the sustainability is sure because they live there, they live with their neighbors, they will continue supporting their families. And we also engage the local authorities from the village to up to the district. They are engaged. We have what we call collaborative meetings every week at a cell level, twice a month at a sector and district level. So they are engaged. We do problem solve together. We share our issues we find in the families. We do find solutions together. We inform them, we update them at their basis so that they can be able to continue the work even if the program is not around. So we hope that that will promote the sustainability of the program and the ownership of the leaders of on this district to work with. Thank you.
Yes. Who determines the change and how to determine the change? That's actually the beauty of qualitative studies, because you might go in a community and you have your own idea of what the change is, because now you are defining the change, or you are defining the benchmark of the change or the success, depending on your background, your own knowledge. But that knowledge and that background might be different from what the people are defining as change, or are defining as what they want, or they're defining as what they think would benefit them. So when you go to the field then, and then you want to learn about the change, especially in the social sciences, as we are now discussing the social sciences, you need to talk to people and ask them, how do they define that change? Because walking on the knees for them might be fine, but for you, it's not fine. But for them, it's fine. And the problem they had was not walking on the knees. The problem they had was something else. And that something else is what change has touched. And then they are happy now. They are saying, now we are happy. For example, they might say, now, like in our context here of Sujira Muryango, the families will tell you, now we sit down with my husband, and then we discuss. And then we agree on who is going to go on the right to get resources and who's going to go on the left. And then they tell you, before, one would wake up and walk on his own way. But today, we now negotiate. We discuss. If a child has made a mistake, in our families, whoever is there would punish. But now today they say, no, when a child has made a mistake, we sit down, we discuss on the best way of addressing that problem. And that's the change, actually, that the project was looking for. And so who defines the change? The people themselves who are feeling the change. And how do researchers know that the change has happened? You need to talk to the people. You need to discuss with them. You need to go by their definition of change. And then also, somebody also asked about the change, the difference between the change that we see 1 year after the intervention and the changes that we see 4 years after the intervention. So that takes me back to my schools when I was taught of what knowledge is. And they would define knowledge as something that remains in your head when you have forgotten everything. So the changes we see 4 years late after the intervention is something that we are celebrating today because we are saying this is something that remained in your head when they have forgotten everything. So if you see that they are now negotiating their children on how to punish their children, and then now they are correcting their children with love, and they are still remembering that this is something that they should be doing, we are happy because we see that after 4 years, there's something that has been sustained. It might be small, yes, but it is there. And it's 4 years after the intervention. And then if we can now bring this idea of sustainability that somebody asked here, Inshuti z'Umuryango now are in the communities and they are trained. And yesterday when we were discussing about the potentials that we have in our communities that can help us to sustain the benefits of the program, we mentioned community engagement. And we know that these evening parents' meetings are there, and Inshuti z'Umuryango are there. So in those platforms that has been created by the government and the existing Inshuti z'Umuryango, which has been trained through this program, we are confident that these benefits are going to be sustained. Actually, the small benefits that we see is likely going to increase because of the existing platforms and the existing community programs that are already there, that has been set already. So we are confident that it's going to be sustained thanks to the existing platforms. So maybe Pacific can also compliment on that.
Thank you for the respondents. I feel like all the questions are cross-cutting, so we are answering, like not pointing to the one who asked the question because they are almost similar. So I want just to compliment on, I'm sorry, I didn't mention the name, but it's the one who asked the first about who determines the theory of change and what tell us that that theory will really work in the context. So as Dr. Dieudonné mentioned, we have literature, we have previous studies that we refer to make our own proposals or theory of change. But as you have seen, Sugira Muryango has gone through phases. So we start with the small pilots, we increase the number of households. So we move through phases. And through all those phases, we are learning from the implementation. And that's why we don't replicate the initial program as it is. Instead, we are including new components. For example, the play collaborative they are saying, so it was not there during the control trial. And now, looking forward, we are going to test the continuous enrollment. All those phases are being informed by the implementation. So we are learning and we are adapting our program across the time. I can also say about the challenges during the program implementation. Maybe I can mention a few and the other may complement. But before that, I can also highlight that we learn through those challenges and we are able to adapt and design new programs trying to overcome those challenges. maybe I can mention the challenges around working with the volunteers. For example, ISOs. So those are community volunteers, they are not paid. And as they are trusted by the community, they are as well trusted by multiple partners. So they may end up having heavy workload. So Sugira Muryango may be using ISOs. Rwamureki may want to use ISOs. So this creates a heavy workload to them and may hinder the implementation of the program. Another thing is that ISOs age advanced. They are limited in literacy, or like education level is not at a high level. So sometimes we come up with our very good tools, data collection tools, our heavy training materials that we want to bring to those volunteers. And we end up seeing that they are really not fitting in their intellectual capacity. But that challenge leads us to the adaptation. Like currently we are revising our tools, our data collection tools. Instead of asking like 20 pages of questions, we are summarizing them to just few and simpler questions. And that also will help us test the sustainability and integration into the normal structures. So I can just mention that challenge, but it shaped us to more adapt to the program. Maybe another question to answer to Christine. So in Sugira Muryango, we are taking all family structures. We don't sample according to family structure. We include single mothers, or dual-headed, multi-generational families, and we adapt, we assign ISO to visit a certain family considering the structure. For example, if it's a single mom, we are not going to allocate a male ISO to visit that family. So to avoid any other challenges, so we will assign a female ISO to visit that single mother. Thank you.
Yes.
Whether we see the differences in the stunting between male and the female children, we don't have an answer to that.
No answer.
But it opens, open up to us, and then going to check in our data whether we can see that difference. But that is not yet answered.
Yeah, thank you, everyone. And I know we had another question from the online that was, how can University of Rwanda students get involved with Sugira Muryango? And I will say contact Joseph Kalisa, his WhatsApp number, I'm just joking. But really, contact the Center for Mental Health, Joseph, Dr. Vincent, and we can work together on how to get more University of Rwanda students involved. And I know we're out of time, and I'm going to be a bad moderator because I want to answer one more question. Because there was a question about the results and how some of the results that we saw 1 year post we're not seeing 4 years later. And for example, we're not seeing cognitive development in those CRT children who are now 4 to 7. But a good thing is that we're seeing them in the younger children. So we're exploring some of those results that we didn't see. So for example, maybe our curriculum is just so good at 0 to 3, but we can do a better job at equipping parents as their children grow older to scaffold activities and to support their development as they grow up. And so that's also something that we're learning. That's been a key theme of this roundtable, is that this has been a learning ongoing, and we're not done yet. We have so much more to do, especially as our goal is 30 districts. So from addressing IPV to addressing what does Sugira Muryango look like in Kichukuru district, right, in urban areas, to addressing how does our theory of change continue continue to adapt as we value participant voices. And so thank you all. And if you have other questions, please do not hesitate to ask. I know lunch has been ready for a while, so thank you for going over time on this roundtable with us. And can we just have a round of applause for our panel participants? Great, thank you. So I think it's time for lunch. So enjoy. Muriherque.
So just quick directions again. So the protocol will be there to guide you for the delegates and speakers. Use the big hall, and then the participants, and we will be using this side entrance. And if we can, we'll have 2 lines instead of 1, so you can go both ways, so which means we have like 4 lines. So that will make it a bit quicker, so don't go on 1 line. If you see somewhere there's a free space, just chip in. And yeah, so bon appetit, see you at, if we can, 1:45. If we can't, see you at 2, yeah? Bon appetit, muryoherwe. I don't know how they say it in Malawi, and enjoy, and yeah.
Hi everyone, my name is Sophia, and in this presentation we're going to be looking
Hello everyone.
after lunch. All right. So first, Yunane is going to walk us through the beginning of this talk on funding your research. We're going to try and give you some practical tips, and then I'll pick up the second half.
Thank you very much. Funding your research. Want me to stand there? Okay. Great. To be able to be moving the screen myself. Funding your research. In other words, let me use now a simple word. How do you get money? How do you get money for your research? That's what it means. Funding your research. Because research is expensive. Yeah? So you can't say that you have 1 million Rwanda francs, that is $1,000, and you say, I'm going to do research. That is not possible. You need money. Also, remember, when you are doing research, you are doing it for the public good, for the interest of the country. Do you fund your research? Oh, sorry. Yes, we are going to talk about in general, the overview of funding in general, or the landscape of the funding. How does it look like if you see in the whole world of this money that we use for research, and then find funding. How do you get money now for research? Where do you knock to get that money? And also now, once you are prepared now to start applying for that money, how is your profile important? And how do you write your proposal? So I'm going to speak about the current landscape of research in general, and then how do you build your profile, and how do you write your proposal to get money? Okay. Now, when you see how the money for research is distributed in the world, some of the senior researchers here in the room would be convinced with me that there is a lot of disparities in the distribution of resources or distribution of research for money. I mean, research dollars, or the dollars you use for research. So in some areas, there's a lot of money. In some areas, there's no money at all. So you can see here, low and middle income countries are most affected in the less funding of research. When we say low and middle income countries, here we are talking about less, sometimes we use the concept of less industrialized countries, or generally the global south in general. You find those countries mostly in Africa. You find those countries in South America, but in South America, some countries are growing. When I was a student, we usually added by default Asia, but today we have some of the countries now which are no longer with us, which are no longer low and middle income countries, which are now developed. But these are the countries, as you can see, the colors. Low income countries, you can see they are mostly in Africa. Low middle income country, you can see they are also in Africa and some parts of Asia and some countries in South America. Now, upper middle income countries, you can see we have South Africa, we have Botswana, we have Namibia, you can see in Africa. We have Angola, you can see Angola there. And then we can see we have some other countries up there. That's Egypt. I think that's Egypt. Egypt or Libya, maybe. That might be Libya. Yeah, maybe before Gaddafi. Now we are saying these are the countries. So we are saying that low and middle income countries are the most affected when it comes to the distribution of resources or the funding for research. So when you see the funders, 10 major funders in research, you find them in the US, you find them in Canada, you find them in the UK, you find them in Japan, you find them in Europe, none in Africa, and in Asia we see Japan. Now, when you see the distribution of funding for research, for example, as of 2020, the money that went to research, there were $37 million, and, billion, yes, $37 billion. And you can see in low and middle income countries how much money went there, 0.5. Only 0.5. The remaining money went to high income countries. Yeah? So that's the disparity I was talking about. So there's this disparity whereby the river starts from the river of money for funding starts in the high income countries and it ends there. Very few water can flow to low and middle income countries. Only 0.5 of all the money that was spent on research came to low and middle income countries. So now, high income countries spend on research and development. So they build their development on the research findings. Yeah? So like if you want to start something, most of the things we use, they are made there, you know that, right? And they are products of research. That's why they have a lot of money. So research and development expenditure in sub-Saharan Africa, if you can see this picture that you see there, I don't know whether you can read. Let me see whether this works so that I can point on some of the things. Yes, it works. You can see that these countries, sub-Saharan Africa, which has this color, can you see how much they're spending on research? They are only spending less than 0.36, you see? Yeah? So these are the countries, you can see that's the area where we are standing now. You see? This might be Congo. This might be Tanzania, you see? This might be Kenya. This might be Lake Victoria, so this country here might be Uganda. You can see here, this country is here, yeah? You can see how much the government is spending on research. You know, in African Union, they have decided that African countries would be spending 1% on the budget, but very few countries in Africa are actually spending that money on research. You can see on the second color, which is also that color, this is Russia. We see most of the Eastern Europe. How much they are spending? They are going a little bit above 0.36 to less than 1% actually. This is all these countries, they're spending less than 1%. But if you see other countries which are spending a lot of money, these are the countries which are spending a lot of money. Oh, it has gone, yes. Which country is this? This is the United States, right? And which country is this? This is Canada. So this country is spending, oh, this is Alaska, right? Yes, they are spending above 2%. 2% of their GDP. And remember, their GDP is also very high. So now if you can take 2% of all that money that is spent in that country, it is spent on research for development, you see? So you can see no wonder that these countries which are spending a lot of money on their research for development, these are the same countries which are also leading in development process. Yeah, so now those countries, 10 countries account for 80% of research funding worldwide. Only 10. So this is actually the disparity I was talking about. So if you see the funding in general, there's no equality, unfortunately. So some countries are getting a lot of money, 10 countries, 80% of the money. And you can see even on this figure, you can see it. Yeah, up here, above 2%. Which country is that? High-income countries. Now, look at this other one, low-income countries. Can you see where we are? Down here, below 0.5. Yeah? So this is the disparity I was talking about. So now I think you understand what I meant when I say that there's a disparity in funding research. But this problem has been documented. You can see this is a list of papers that has been published which are talking about the problem of funding research. For example, this one that has been published in the PLOS Global Public Health, they are saying that funders, the missing link in equitable global health research. So this paper would be documenting that problem of funding research for health. Now, this other paper here, which was published in The Lancet, why we need a global fund for health research. This one also might be describing that if you want to address this issue, we need to have a global fund for health research. So I think if some of you know what the Lancet Global Health is the leading journal actually in public health. This is one of the leading journals in public health. And this one also is talking about that there's not enough, is it traction? Barriers that aspiring researchers from low and middle income countries face in global health research. So that problem of disparity in funding research has been documented. Yeah? So it is not a secret now. We all know that there's a problem. This happens while the Sustainable Development Goals calls for enhancing scientific research, upgrade the technology capabilities of industrial sector in all countries, in particular developing countries, including included by 2030. There's this call by the Sustainable Development Goals, especially point 95, Article 95, that this funding should be equally distributed. We should be developing our technology based on findings on research, but still the funding for research in low and middle income countries is not enough. Now, if you are aspiring to do research and you are from Africa, you are from Rwanda, and you know that we only have 0.5, less than that, actually, funding in our countries, how do we find money for research? How do we get money for research? Yeah? How can we struggle now to get on the table when they are negotiating funding for research? Yeah? There's hope. There's still hope for that because some of the researchers in Africa are actually doing some good jobs. And how are they doing to get that money for research? That's actually what we're going to discuss. The first slides was about showing that disparity. You saw it. Now we're going to see how do you find money for your research. I have here this figure, which is showing us how a researcher grow. How do you grow into a researcher? How do you start? And how do you grow? How do you know that now you are an established researcher? You start small. You start small, and then we have what we call small grants. We have what we call medium grants, and then we have what we call large grants. When you read those proposals, you find that actually the small grants, they are more of doing explorations, kind of, exploring the problem, how is the problem behaving in a particular society. So if you're writing, thinking of exploring a particular problem, and then that would be a small grant. Or you might be doing a piloting, an intervention maybe, for example, you have discovered a solution to a problem that you got, for example, when you're doing explorations, and then you want to pilot the solutions and see whether it works. Then you need relatively big money compared to small grants. Yeah? And then if you want to now to check the randomized control trial, like you take one wing people here and take another people here, you do intervention, mostly they are intervention studies, randomized control trials, you need a lot of money. And then you need to implement that project relatively in a long period of time. In terms of numbers now, how would I say that this grant is small? Well, I don't know how small it is. It depends on what you think, but I think anything from 1 million Rwanda francs or $1,000 up to 50 million Rwanda francs or $50,000 can be small. It can be small. If you want to do an exploration, that budget can help you. Yeah? So when we say small, that's what we have in mind. But also a medium does not start exactly at 50 plus 1, yeah, because there's no straight line on that. But maybe something starting from 10 up to 100 million Rwanda francs. We can say that this is a medium. You can do a piloting if you have that budget. Yeah? If you have that budget, you can do a pilot. And if you want now big money, large money, like when you said you want to do a randomized control trial, yeah? You want to see whether a particular intervention is working. If you compare people who are eligible for the intervention and people whom you have not selected for the intervention, and then you want to compare maybe this budget, yeah, a budget of $1,000 or 100 million rand francs to $1 million. It can be a big or large grant. But there are people who can win over than $1 million, right? There are people who can win $5 million. There are people who can win a grant for $10 million. But that is going to be now a study that we're going to do for a long time, involving many people, most of the time multi-country studies. Then this is going to be a large grant. So when we say small, medium, large grant, this is what we mean. Yeah? Now, how do we get money for research, and where do we get that money? So if you want to do an exploration or a small grant, you can get a small grant from your institution. You can get a small grant for your institution. Maybe your institution might want to check whether a particular idea you have is working. The institution can give you small money, and then you can use that money, and then you can show whether it works. In some contexts, university-wide, at the university level, they might advertise small money, or you are working in a research institution, they might advertise for small money. In some contexts, departments, but in Rwanda, I don't know whether departments can offer grants, no. But at the university level, for example, we're going to see in Rwanda where you can get money for research, or societies, or clubs, or professional societies, like these associations that we have of medical doctors, of clinicians, or something like that. They can give you small money. Remember, we're talking about small grant. Or you can get money from the community if, for example, in a district, they see that there's a problem that they want to address, and they know that you are a researcher. They might want you to write a small proposal for a small grant, and then you get that money. Or a local non-profit organization, an NGO that is working from a particular place. You know, if you're working in an NGO, that sometimes there are grants that they give, and these are small money or small grants. Now, if you are looking for a medium grant, where do you go? You go to philanthropists. Philanthropists, for example, this is unique for research priorities, missions, visions. So they define what they want, they advertise, then you apply. Yeah? Or they contact you if they know that you're a researcher, then you apply. Okay? That this is now from funders. It is now beyond the university. Or the big 10 funders, you might see that they are finding medium. Remember, medium goes up to 100 million rand francs, or $100. Like NIH, for example, in the US, we have MRC in the UK, we have these organizations, we have Wellcome Trust. I'm reading the ones that have, I know very well, that have applied for. Yeah? These are the grants, the organizations that are providing funding, the medium grants. They can give you money up to 100 million rand francs, or $100,000. Or national councils and societies like fellowships, career development grants. In Rwanda, we have some of them. We're shortly going to see what it is in Rwanda. But before we go there, let's go see who are funding large grants, who are likely to give you big money that we said can go up to $1 million or even beyond. This can be, for example, private funding. If there's an organization which is providing a lot of money, so for example, the national or international philanthropists, that are people who are giving money to do work. We're going to see a list of them here shortly. Public funding, for example, the government's providing the money for research, yeah, so they can give a lot of money. Remember, they're providing this money to try solutions to a problem which is there. They're not giving money for yourself, no. It is for you to solve a particular problem which is in the society. That's why they are providing big money. Now, in Rwanda, who might be funding research in Rwanda? Yeah? The government of Rwanda provides some money through the National Council for Science and Technology. If you can go on the website, there are even some grants published there. So they advertise, you apply, they go through your application process and so on and so forth. So the money that the government of Rwanda gives to research, you find them at the National Council for Science and Technology. But also your institution can provide money. So for example, the University of Rwanda, through various partners, you might find that they are advertised. Yeah? You need to check on the website if you want to see whether that money is there. And that money can be a small money or medium grant. You might find them there. Yeah? Now for Africa, there are funders who fund African researchers. What I have selected here are the leading organizations. The African Union Research Grant, the African Union has some money. So if you're interested in doing research, you can be visiting their website. There are some calls about research. The African Academy of Science, they have various areas of research. They fund various research. This organization, actually, I know that they are providing funding for many researchers across Africa. So African Development Bank, they provide grants, mainly grants that promote economic and social development in Africa. So these organizations mostly, they provide relatively big money or medium grants. Carnegie Corporation of New York, they're one of the funders in African researchers. For example, they fund education, research, and higher learning in Africa. So they fund capacity building in Africa, and they provide relatively medium grants and even large grants for Africa. We also have Wellcome Trusts. Wellcome Trusts, it's a UK funding, so they also provide funding while primarily a global foundation. Wellcome Trust funds research projects worldwide in Africa. They even have small grants, they have medium grants, they have large grants on the website of the Wellcome Trust. Together with the Bill and Melinda Gates Foundation, I know them, they also provide funding for African researchers, African institutions, and they provide medium and large grants. So the United Nations Development Programs, they also provide funding. How do you know that these funders are providing funds? How do you know so that you can apply? Visit their websites. You need to be visiting their websites because you may not get somebody to tell you. But if you have somebody tell you, that's fine. That is going to be your mentor. So talk to your mentors. Talk to your mentors. And you need to enlarge your mentor network. Yeah? You need to have people who are connected, who have information, who can help you to have those information. You see? So you can also sign up. You can also sign up to receive newsletters and funding announcements. If you go to the website and you see that they are requesting you to put your information there so that they can be giving you information on funding, on the upcoming information, fill it in. And once you get it, read. Yeah? Also, follow local, regional, national, and international politics and news. Why do you need to do that? Because you need to know of the leading problems that the politics is putting forward. Because remember, as I told you, only research that is aiming to solve a problem will be funded. And how do you know that problem? You follow news. You follow politicians. And then, how do you know that the funders are providing money? Visit their websites. And also, talk to your mentors and make sure that your mentor network is large enough. Thank you very much.
So just to wrap up that section really quick, we gave you a lot of information on where to look to find funding, and obviously that would be a lot of homework if you were to go through, and you can really get buried in all of the potential funding resources. And so there's a popular book in the US, a professional development book. It's called Your Network is Your Net Worth. And actually it's not what you immediately think. It doesn't have to do with your financial well-being per se. The purpose of the book is to point out that your strongest resource is your social capital and your relationships and your network. And so I call it a shortcut, sort of, because if you foster a network of mentors and colleagues who are interested in the same topics, you will probably be informed of targeted research requests for proposals that align with what you are trying to do. So in the sense that that gives you a shortcut to know, okay, who are the funders that focus on this area of research? What do those funders want to see? Your mentor network are some of them are probably funded by these funders. And so it is a shortcut in this sense, but it's not in the sense that it does require authentic engagement with your mentorship network. So you don't try and build a relationship just to know a person who might be able to help you. In fact, ask, what can I do to help my network? Because it should be an exchange. And by establishing this really rich network of colleagues that work in your area, it will facilitate your ability to find really targeted research that will work for you. Okay, so funders are going to want to know about you when you apply. They want to see a profile that makes you look like you can handle the grant and the money that they're about to give you. So how do you prepare your profile in order to make funders really drawn to your application? The application we'll talk about next, but you also have to present yourself in a way that demonstrates your capacity to actually deliver what you say you're going to deliver. So we have some information here about how to develop that profile. What are funders looking for? The ultimate question. And we can kind of categorize this into 4 main groups. If you're talking about kind of pie in the sky foundation funding that funds risky things, more experimental things sometimes, they might look for stuff outside of this list that's eclectic and about you per se. However, in general, funders are going to be looking for these characteristics. Number 1, your training. Do you have the specialization, the expertise, the degrees? Unfortunately, it often does require a particular degree level. And they also look at your institution. I'll expand on that below. But obviously, if institutions have a history of obtaining funding, that will also look good for you, and that's part of your profile. Your experience. So, have you managed previous grants? And that's where that funding pipeline comes in so important, because you can start out large, but you won't likely get funded. Speaking from experience, funders want to see that you have evidence that you have managed a grant and delivered what you intended to deliver, and you want to see a growing pipeline of funding amounts that you have supported or led in some capacity. Publications, the currency of research, for better or for worse. They do want to see demonstration that you are an expert recognized by your peers on a particular topic. So to the extent that you can demonstrate that through your publications, will strengthen your application. Awards or distinctions, anything, again, that reflects that your discipline recognizes you as an expert or knowledgeable and capable of delivering on this research. Next, your ideas. We'll talk about this a little bit more in the next section, but you do have to demonstrate a few characteristics of your research. These tend to be kind of common in my experience across kind of medium funding applications. You want to demonstrate scientific excellence or programmatic excellence, if that's what you're focused on, the significance of your research, and the impact. And significance and impact can seem to really overlap. However, impact is really talking about what your research can, the implications may be interdisciplinary implications for larger society, implications for industry, things like that. Whereas significance is what is the, I don't want to say what is the significance, but basically showing that this is an important problem. And then, of course, your institution, as I mentioned, needs to show that it has the capacity to manage grants that will strengthen your application, that it has the appropriate space, equipment, and materials for you to conduct the research, or the funding will cover that. And then, of course, in general, the quality of the research infrastructure. So those are things that you really want to think about. How does my current profile reflect these particular interests of the funder? So in order to make sure that you're able to do this, a couple of tips. Number one, keep your resume or curriculum vitae up to date. You can always pare down later for a particular proposal, but document everything. Make sure you have it all in one place so that it's easy for you to access. You also need to have a kind of personal narrative. I don't know about anybody here, but my background is pretty eclectic. I won't belabor that point, I won't go into detail, but my background is pretty eclectic, so you have to help funders understand how that background supports your ability to deliver on that grant. And so then the last piece is you have to be ready to tailor everything. You don't want a CV and a narrative that you just send to everybody. It should really reflect the priorities and interests of the audience. I'll talk about that more in the next section. So I've suggested here a little homework assignment for you to develop the narrative piece, because many of us may have a resume ready to go, but the narrative piece is a little bit different. So I've suggested that folks try out a NIH bio sketch, which includes narrative description of your background. And so you can actually go to the link here and it will give you the template, it will give you the instructions, and here we have an example. So what you can see that is included in this example is kind of your wrong button. Well, anyway, at the top, it's your basic information. Then your personal interest statement. And the one that I pulled here, which unfortunately is it's hard to see for everybody. But the personal interest statement in this example is specifically for someone applying for a fellowship, a pre-doctoral fellowship, for example. But if you are more senior and further along in the pipeline, you might look at the non-fellowship example. So it just depends where you are. So you need to describe your interests in a way that reflects the funder's interests and goals and demonstrates your capacity and expertise. It's also going to have you describe your positions and appointments and any other meaningful aspects or milestones in your career. You will also include honors and awards. Again, that distinguishes you from other people. Your major contributions to science. And then for a fellowship, it would be your kind of academic training. So, your proposal. We do not have time to help really refine your proficiency in this. This is a long-term skills development process. However, we can offer a few tips to get started, and I'll just briefly cover each one. They are know your funder, follow the format, learn the evaluation criteria, and revisions, and revisions. So, first of all, knowing your funder. I have a little bit of a checklist. I tend to be a little over the top about this part. However, I definitely spend the time getting to know my funder in depth before I start writing, which is why I'm always starting writing a little later, but it turns out to be worth it some of the time. So first of all, make sure you read all of the materials thoroughly. Sometimes that's a lot of materials. Sometimes you have to read multiple documents, and it's a lot. So you want to give yourself enough time to do that. But you do want to read all of it because that's really going to shape how you write this proposal. Number 2, review the funder's website. Read about its mission, values, goals, and current initiatives in particular relation to the opportunity that you're looking for. That's going to help you understand how the funder thinks and how your proposal might reflect that thinking. Download published reports on the funder's activities and current and former grantees. Many funders tell you who they funded before, which is great. That's a huge resource for you because you can take a peek and see this was a successful proposal. What did they do? What was the scope? What was the topic? And you can really get a lot from that. Where possible, find previously funded projects and try to learn about their scope, framing, and achievements. Where possible, engage early with program officers or the institutional staff to share your ideas, see if it fits within their portfolio. You want to be prepared for this, so that would be reaching out to your mentors to make sure you're really prepared for that step. Sign up for their newsletters. It will help you, again, understand their values. And then, of course, drawing on that expertise of your network. Follow the format. So grant proposals, particularly, well, some small grants, many small grants, but also just from medium on up, you have to be precise. That includes like the font, the spacing, the margins, all of that stuff. Make sure your proposal fits that. But the other piece is that often with these opportunities, they will give you an exact outline of what they are looking for. You literally want to copy that outline into a Word document and write your text within that outline. That ensures that you've covered everything that they're asking for, because reviewers, their evaluation criteria, which we'll talk about next, also align with that outline. So you want to make sure you cover everything. If you don't know how to answer a section, talk to your network, okay? Learn the evaluation criteria. The funders will often provide this directly to you in the application materials. But there are some sneaky ways to learn more about those funding evaluation criteria. Number 1, read a successful proposal. If you have a colleague who has been successfully funded and they're willing to share that with you, that is a huge resource for you to see the funders liked this. They gave them money. I obviously need to understand what they did and apply it in my own proposal. Dig into the funder. Although they may provide you the evaluation criteria in the application, they may provide further information on those criteria on their website. They may offer training on those criteria. you can also look for the training for the reviewers on their website, because the reviewers also need to know the criteria. Sometimes that training is public. And last, if you have the time, because it's not trivial, time investment is become a reviewer. Then you are on the other side, and you can take what you learn from that experience and bring it into your own grants. Last, revisions. So just as an example, the US-based NIH, National Institutes of Health, usually you expect to write your first proposal, like a career development award, in the first year. Then you get rejected, and then you submit it again the second year. So really, you need to be preparing that proposal 2 years in advance of when you want it, if not more. Okay, so you absolutely have to start early. Practically speaking, sometimes you don't get to do that, but to the extent possible, really get started early. So you want to start with brainstorming your ideas, check with your mentors. Do these ideas make sense? Do they align with the funder? Formulate the plan. What is the research going to look like? Check with your mentors. Does it align with the funder? Does it make sense? Write a draft. Then write another draft based on feedback, and then a third one after that. And then just keep going until it's ready to be submitted. And the first one is usually not. And then add your final touches, make it nice, make it appealing, make it easy for the reviewer to read. Don't underestimate that aspect. If at first you don't succeed, try again. In a lot of cases, you won't get funded your first time, or your second time, or third time. Don't give up. You're learning a skill. Make sure that you learn from your mistakes. Funders often provide feedback. When they provide feedback, read it thoroughly. Talk to your mentors about it. I say the reviewer is always right. I don't mean maybe they're always factually right, What I mean is, if they say, you didn't say something that you're like, yeah, on page X and X, I said that, you're still wrong, because you didn't communicate it well enough for that reviewer to be able to understand the relevance of that text in the scope of your proposal. So make sure that you take that feedback to heart, and then, of course, have ongoing discussions with your mentorship team. Thank you.
Yeah, that's what we had for you as part of capacity building.
If you have questions, reach out to us later in the afternoon.
Maybe whether we can receive like one question or two?
We don't have time.
We don't have time. Okay, so if you have a question, you can approach us. We'll be seated over there, and we're together even tomorrow. Please come to us, and we can help you more. Thank you.
Absolutely, and these slides will be shared with you, as well as the email for both Candice and Dr. Diodone as well, so that you can ask any follow-up questions that you have, because this was an incredible session. I'm sorry we don't have more time. So next, for our next round of presentations and panels, I will welcome Dr. Alan Ahishakaye to the stand, as well as Chenjezo Grant Gonani, who will be our facilitators for the next session, and they will welcome our next speakers, and we will go from there.
Good afternoon. So, welcome to afternoon presentations. And this session will be moderated by myself, Chenjezo Grant Gonani, and my colleague,
Alain Ahishakiye.
So who are you, Ellen?
I'm a medical doctor and pediatrician by training. I am a research fellow at Center for Mental Health. And I'm doing my master's of medical science in global health delivery at Harvard Medical School.
Thank you so much. I'm Chenjezo Gonani. I work with Partners in Health in Sierra Leone. as a mental health program manager. I've been there for 3 years, originally from Malawi. I'm so thrilled with the presentations here. And because we are also implementing similar models in Sierra Leone, and I think part of our work also we share here. And I've spent years looking at modalities, innovations, where we can build access to mental health and psychosocial services to the vulnerable populations. So we are so privileged to have this session, to welcome our distinguished presenters. I think we have 3 presenters.
Yes,
Go ahead, Ellen.
please welcome Edouard Sibin. Welcome. Welcome, Dr. Elizabeth. And Dr. Mushashi Christine, welcome. Thank you so much. Welcome.
Thank you. So we have these distinguished presenters, and I'll just give a bit of their bio. We share that. So Edward is a global health researcher who holds a Bachelor of Arts degree in demography and a Master of Science in Project Planning Management. Is an alumnus of the International Citizen Service Fellowship, as well as the alumnus of Mandela Washington Fellowship. At present, is a co-investigator for 3 global health studies funded by Grand Challenges Canada, implemented in Zambia by Contact Trust Youth Association on adolescent health and mental health. That is a therapeutic art. And I think this afternoon we'll be sharing the incredible work on an exploration of barriers and facilitators shaping the implementation of the adolescent mental health interventions, a case of Livingstone and the Kazungula district, Zambia. Over to you, Ellen.
Yes. After Edward, we're going to have Dr. Elizabeth. I will introduce her after the presentation from Edward.
Good afternoon, members of the Symposium. Yeah, my name is Edward Sibene from Zambia, the southern part of Zambia where you find the Victoria Falls. I'm here to present our study, which is entitled An Exploration of the Barriers and Facilitators Shaping the Implementation of Adolescent Mental Health Interventions, a case of Livingstone and Kazungula district. So Kazungula district is also in Southern Province, as well Livingstone is also in Southern Province. For some of you that might be aware, Zambia is a very young population with a median age of 16.77, which is equivalent to 17. From this young population that you are talking about, over 45% of Zambia's population is below the age of 15. And an estimated 40.9% of children experience deprivation in the form of lack of access to nutrition, number 1, education, health, water, sanitation, and adequate housing. In a country that is focusing more on the acquisition of the basic needs for survival, mental health needs and concerns are not usually a priority, and most of these are not paid much attention. And thus, additionally, there is also a problem when it comes to lack of data on mental health in Zambia, because we don't have mental health care services at primary level. Okay, whichever health facility that you're going to go to in Zambia, you're not going to find any mental health care services available, especially for young people. Further to that, the stigma surrounding mental health conditions is a significant barrier to mental health service utilization, especially for young people, because there are so many beliefs around mental health, as it is usually associated with witchcraft. Some people would say these are demons. Some people would say this person was bewitched, because there is not so much awareness around the subject matter in Zambia. Okay? Further to that, with a little interventions that are available from the private facilities or private institutions, which are quite expensive, existing approaches are reliant on talk therapy, which works on the assumption that the client already understands and can express their challenges. However, art-based approaches, in contrast, are more accessible and destigmatizing, and have been found to help young people connect with their peers, cultivate self-awareness, express their thoughts, and feel creative. The objectives of our study was aimed to explore the barriers and facilitators shaping the implementation of adolescent-focused mental health interventions in Zambia. Our specific objective, number one, was to assess the acceptability of therapeutic art as a mental health well-being intervention among adolescents. Specific objective number two, to identify the barriers and facilitators shaping adolescent access to mental health information and services. Specific objective number three, to explore stakeholders' perspective on how youth mental health can be addressed. The methodology. Our study was basically a purely qualitative case study approach, where we are trying to dive into the experiences and the perceptions of young people around mental health. We did 53 key informant interviews with healthcare providers, teachers, adolescents, and young people with lived experiences of mental health. And thematic analysis was used to analyze the data. We used NVivo, those that are familiar with NVivo. Yeah, so this study is part of the ABS project. So ABS is Art Beyond Schools. It's part of the Art Beyond Schools project, which is piloting the following. Number one, feasibility and acceptability of using young people, working with young people to deliver therapeutic art to improve mental health outcomes for their fellow young people, which is a task-shifting approach where we are getting higher level skills and teaching them to young people so that young people can reach to their fellow young people. Number two, we are also looking at the feasibility of the provision of therapeutic art at the primary healthcare level, something which has not been done before in the Zambian context. So this Art Beyond Schools project, we are delivering it at three levels: at the school level, at the health facility level, and also at the community level. So at the school level, we have recruited 24 mental health champions to deliver weekly art-based mental health education sessions in 10 schools. So these 24 mental health champions were trained in art therapy that they are able, that they are able to deliver to their fellow young people. At the health facility level, we recruited 12 health facility staff, where they are also going to be supervising these 24 mental health champions at the facility level, in the youth-friendly spaces. At the community level, we have established 2 after-school clubhouses, where young people can go in groups for group therapy sessions and also individual art therapy sessions by qualified professional therapists when they are referred by the mental health champions from the schools or from the communities. Straight to the findings, therapeutic art was seen as an effective strategy to improve mental health and well-being among adolescents. Talking about the barriers, young people face several barriers, such as lack of information, that's number one, stigma, that's number 2, and judgmental approach by healthcare providers and other health systems challenges. That's why in our models, we are also training the healthcare providers so that they can know how to deal with adolescents when they visit these facilities. On the facilitators, we are saying school subjects which discuss mental health, interpersonal communication through counseling and peer education, strong linkages and awareness raising were seen as facilitators to access. The other facilitator that came out strongly was strengthening collaboration between the education and the health sector. This is because the pupils in the schools are regarded as learners and by the teachers, but the same pupils are regarded as clients by the healthcare personnel. However, there was no synergies, there was no linkages between the two ministries. Using our model, we've decided to bring these two ministries together for the betterment of the lives of the young people. And also meaningful youth engagement and creating an enabling environment through peer-to-peer interactions we are seen as avenues for solving youth mental health challenges. Implication of practice, this should be my last slide. Results show a need to meaningfully engage adolescents and young people in a co-production approach, which is the human-centered design, where the young people themselves are part of the solution and where the end users are also part of the co-production models approach to mental health interventions. In addition, there is a need to strengthen health systems to be responsive to the needs of young people by building health providers' capacity in youth-friendly methodologies. This is like health systems strengthening approaches. Thank you so much.
Thank you so much, Edward, for the incredible presentation. So the audience can just keep questions so that after all the presentations, then they can be answered together.
I'm going to introduce Dr. Elizabeth, who is our next presenter. So Dr. Elizabeth has always been firstly passionate about the mental health well-being of children. After receiving her MBCHB in 2013 from the College of Medicine and Allied Health Science, Elizabeth worked with Aberdeen Women's Center, a hospital that provides maternal and child care in Sierra Leone. Inspired by her 4 years at Aberdeen Women's Center, Elizabeth went on to receive her Master's in Science in Advanced Pediatrics at King's College in London in 2020. Through her academic research, Elizabeth discovered that there is no children's clinic in the country. What followed was a fervent push to fill this gap, including tapping into her network, a GoFundMe campaign, and conversations with funders and key actors in Sierra Leone. Dr. Elizabeth, the floor is yours.
Good afternoon, all. I'm so happy to be here telling you about our story in Sierra Leone. I know you've heard a lot about Sierra Leone, about what's happening, the trauma, the issues, but this is like a twist because this is like solutions, like what we did or what we're doing in Sierra Leone. So all of us know about Sierra Leone, the history, the Ebola, and what WHO said is around 10% of Sierra Leoneans do suffer from mental health conditions. And despite this high prevalence, we have currently 3 national psychiatrists where we have only 1 functioning. And the good news is we have a residency program that's just been approved. And with the help of PIH, this residency program will, in the next 2 years, graduate 8 residents, 8 specialist psychiatrists, which I'm one of them. In 2017-2018, PIH reformed the oldest psychiatry hospital in Africa and the oldest psychiatry hospital in our country up to date. And PIH has a system where they support staff, they help in social support, the system strengthening, they have space and stuff. So these are like the 5 S's which PIH they believe on. So these are just pictures of when we were dealing with chains and when chains were off. And this was the new refurbishment done by PIH and up and running now. This is the residency program, and this is Professor Gaviola, who came, and he's one of the pioneers in starting up the residency program in Sierra Leone. So, what came about the Child and Adolescent Mental Health Unit is in 2019, 2020, while doing my master's, I found out we didn't have any Child and Adolescent Mental Health Unit. And going through studies, I found out we had a 99% treatment gap for children. So children weren't going untreated, going into adulthood. And studies have shown 70% of children with mental illnesses end up having mental illnesses in adulthood. So catch them when they're young and you manage them. So we had nothing. And I said, we need to find a space. And we only had this old psychiatric hospital that we had the Sigma. But good news, PIH had this new wonderful building. Then I said, we need to find donors, we need to find partners. And it's like almost impossible. Then I have friends, I had people, we spoke with them, and I had a very close friend, did a GoFund with the help of PIH, with the help of Vista Bank. So I did like a public-private partnership where different people came on board and we set up the unit. So setting up the unit, we started thinking, who is going to run this unit? We have no child psychiatrist because this has been the issue. We have no social worker. We have no psychologist. Then I said, we need to start somewhere. Okay, I'm a pediatrician. I've been working with children. I've been working with children with immigration issues, with migration, refugee. Let's start. And with the help of Harvard University, on Thursdays, when we go through, you'll see, because I'm not a child psychiatrist, but we needed the program to start, on Thursdays, we present cases to them and we co-manage through teams. So going on, I thought it fit. We had these awareness issues. There was a big stigma on child and adolescent mental health. Then I said we need to start with the schools because children spend most of the time in school. So we need to let the teachers know, the students know about what's happening. They need to understand the signs and the symptoms because even the teachers, they don't know. It's not because they're like, oh, let's just leave them. No, they don't have an idea. So we came up and we started up to date. We have done 80 school visits. All have been like public schools. And now the impact has been schools are calling us now to do awareness campaign where we teach the students, we teach the teachers what to look out for. What is mental illness? What are the early signs and what we should do? And on Mondays also, by the help of PIH, we do EEG because we found out like 90% of our patients have a comorbidity of epilepsy, which once it's not treated, it's continued with the mental illness. So we're doing EEG for all new patients. And on Tuesday, we do home visits. So I was very thrilled when I heard about Yes, the home visit, and it was typically what we're doing, where we go to the homes, we evaluate the environment, safety, and recommendations, and what's needed with the social workers. These are all volunteers. This is just a picture of the team going to one of the homes, and what they do, they talk, do a little bit of play with these children, explain to these patients. And this is what we normally do on Wednesdays, a psychiatric review, pediatric review, and recently, about 2 months ago, we've started a psychological assessment for all of these children. She's also a volunteer. I called in and said, you know what, we need to do something. We have to start somewhere. So currently, all of our children are being assessed for psychological issues. And on Thursdays, this is what I was just explaining about the teams with the Harvard doctors. So we'll come in with the patient, and we explain, do case management, and all will do psychoeducation, psychotherapy, all the forms of therapy and what should be done will be addressed on Thursdays. Once it's a new patient, on Wednesdays is the follow-ups. And on Friday, the most interesting part, we do skill sessions and parent sessions. So we thought it fit, we need to start helping these children with skills because they are not going to school. So due to that, I made an affiliation. We started up a special needs school where I also help out the teachers in what to do for these children. So we have a unit and we started a school. So we will train these teachers and we'll also do skills for these children, helping them even with livelihood supports. And the parent session, studies have shown that most of these parents, they have depression, anxiety, they too have mental illnesses. So we're trying to address, so it's a group session where they discuss their issues and the way forward. And So what are the challenges? Definitely knowledge gap. That's the first challenge. We need continuous training for service providers, specialized care for increased needs, because currently we have 270 plus patients, and the units have been up and running for 2 years. We started May 2021 up to date. And the sustainability, because I've explained like 5 or 10 different programs we're running, and it's just with the help of PIH supporting with some of the activities we're doing. And definitely culture, it's the big issue. Addressing the stigma, working with traditional healers. The paper I previously posted, that was the main challenge, the religious and traditional healers. So the way forward, definitely I'm looking to decentralizing this care in the whole of Sierra Leone, and system strengthening, helping the staffs, and definitely working on research, because the whole essence of this was having a data on Sierra Leone. We knew what was happening, but there was no realistic figures. So for 2 years, we have figures talking about Sierra Leone. So we need to go into research to know and find the figures, the real thing happening in our country. So these are just references, and thank you very much.
Thank you so much, Dr. Elizabeth. I think I'm so honored to introduce the next presenter, who is Christine Mushashi. Christine Mushashi is a clinical psychologist. Is a clinical psychologist, holds master's in clinical psychology with working experience of more than 10 years in community work and family promotion as family strength and intervention coordinator with Partners in Health as well as Harvard University. Also has been part of the participatory action research with CBS and rehabilitation, and integration program coordinator with CISDA. So, CISDA, yeah. So, thank you so much. So she will be sharing on evidence-based intervention for children in street life situation. Over to you, Christine.
So thank you so much. I want just first to apologize for 2 things. For the matter of the child protection issues, we're not allowed to take photos of slides, and we will not share our slides because we didn't ask them permission to publish their photos. So we have many photos, and sorry for that. So as I said, I'm Christine Mushashi. I'm the coordinator of rehabilitation and reintegration program in CECIDAR. CECIDAR is a local NGO founded by Rugamba Spirian and his wife. I think many Rwandans know about him. He was a singer, poet, artist. So we have 3 programs, and the main one is the rehabilitation of street children. But currently, we are also running 2 programs as prevention, because the problem of street children is still important. So then you have 2 programs as a prevention. One is ECD program for the little children under 6 from vulnerable families who are at high risk of going to the street. And the second one is what we call after-school programs for children who have been in street life, went into rehabilitation process, and then they are now reintegrated in the school and the families. You saw some of them yesterday dancing. So we have many activities with them, like dancing, football teams, other recreation activities, just to help them not to go back to school, to the street. But we include also some children in their communities who are at high risk to go to the street. So the after-school program concerns children between 7 and 18, while the ACDs are for children under 6. So the problem of street children, CECIDAR has been dealing with it since 30 years ago. It has, if I can say, it has always mutating from displaced families. Then after it was the cause of the orphanage, after the genocide. And today we still have that problem. And sometimes with children from both parent families, or maybe with also the basic needs available. So everyone is wondering what is the problem? So what's the source of this problem? And it's a very challenging problem that every intervener in this field is challenged to know what to do. So what we will be sharing here, it's just our work experience and what we came up of realizing, but more researches are needed. So we found out that this problem might be caused by the parent psychosocial problems, psychosocial distress, which we are trying to address. So 2 reasons were learned. We found out that there is no street children rehabilitation without family rehabilitation, because children are the victims of family dysfunctionality, if I can say, parent problems, neglect, poor child care, so and trauma, because we are finding it a lot. And in our Rwandan culture, we have a proverb saying, aho kwica gitera, wakwica ikibimutera. So instead of just killing the troublemaker, so we have to tackle what is causing him or her to be a troublemaker. So our 8-step methodology, we start by meeting children in their community or where they are living on the street. What I didn't say is that for our 3 programs are community-based. We do all those programs in community. So here you can see some photos of children. You can see some drinking, drugs. So this first step is very important because we meet children, as you can see at the above photo, children at their site, how they call it. We meet the community leaders, like village leaders. We meet parents. And then it's a good time to talk to them, to explain what we will be doing with them. And the children can accept voluntarily to get enrolled in the program. So this step is very key for our success. The second step, it's what we call a welcoming session. Because when we meet them, then we need a time to socialize, to get to know each other. So it's a good session where you can have dance, you can have soft drinks, you can share. If you can see the right photo, it's the same child. You can see the first how he's hesitant to like saying what will be happen, what am I doing here. So, but for the last photo, you can see how he's dancing. So when the trust is built with the child, when he feels loved, cared, and respected, so he's less tempted to abandon the program, because some children abandon the program without, don't know why, but they abandon. So it is very key also that they feel like a safe place, they feel safe, they feel welcomed and not judged, so that they can go into the rehabilitation process. So for the rehabilitation work, we have many activities, because those children that the streets, they have lost a lot of their skills. So our rehabilitation work focuses on physical, psychological, social, intellectual, and spiritual aspects of the person. So we do many psychoeducation, group and individual therapy. We do different exercises to educate concentration, teamwork, self-esteem. We do many physical activities, like dancing, playing football, so that they can express their emotions. We can their negative feelings and forces. We try to put them to the good way. And they have time also for group and individual therapy, as you can see, that every child is unique, that we can be treated as unique. The first step is the family visiting and tracing. So when we visit families, generally we meet the children, and some parents didn't know that we met their children. So it's important to go to the family to see where the child comes from, to see the composition of the family, and if possible to know the large family members, so that they can be helping in finding the solution of the problem. So visiting the families also engage them to work with them, to understand, to analyze the problem for an effective intervention. Because as the child is unique, and every family is also unique. So they don't have the similar problems. So after the home visit is done, we have the sessions for parents. So our sessions focus on child rights, positive parenting, trauma healing, resilience, capacity building, conflict management. The couple you see on the right, it's not dancing, it's just arguing. So we can offer the couple therapy, but it's a good thing that they can even express to us what their problems. So that couple did have the misunderstandings, even to the sessions. They are about to fight, so we were here to listen to them. So when the sessions ended up and the children are ready, so at the same time we are rehabilitating the children, we rehabilitate also the family, and at the end, when we found out the child is rehabilitated, can go to school, the family is ready, and even if the family is not ready, we can find other family members or another alternative care, so the child is reintegrated in the family and the school. This is an activity done in collaboration with local communities, parents, and the local authorities, and we engage all of us for the stability of the child. So then we provide the school materials and other school requirements. The child is going to school, and then the next step will be the family strengthening. So as long as we work with the family, we came up to realize what is the main problem for the family. So for some families, it can be like trauma issues, others can be some psychosocial problems, others are the homeless families. So according to the problem of the family, we found a solution together. So for some, we can, with the small money we have, we can give some the shelters, because there are some families which are homeless. Some families can relocate from cities to their villages if they have, or find another village to live in, where their life can be more manageable. And also some might need some more treatments, or others can, so it depends on the problem of the family. We have also associations where we gather them into associations in their respective villages, where they meet each month, each 2 weeks, depending on their availability. And then we can do also some income generating activities, and they do also saving and credit themselves. The last step is the follow-up. Whatever we can do, if there is no follow-up, what we have done could be just be lost. So the follow-up focuses on family visiting to see how they are doing after their integration, to visit the associations of parents, just to address all the issues of new ones, and also to meet children during holidays. So to have that time to come, to listen to them if there are new challenges, and help them to solve them. So those are the way we go through for the rehabilitation. It's where the children who came here dancing went through this program, this system. So from the streets, they become the good traditional dancing club. So this methodology has shown to be effective from our follow-up study. You can say that 70% of children are remaining at home if we are doing well this process. The methodology requires an intense work with and within the community, because it helps us to get in touch with problems in the community and society and try to find together the solutions. So psychoeducation has been a tool that we have used in raising awareness of trauma for families and the communities, because sometimes when we talk to parents and learn about trauma, they say, I didn't know that I have a trauma. I think maybe because we're always arguing in the family, I didn't know the problem. So then I can realize that we have trauma in my family, so then they can look for professional help So a community-based approach is effective in dealing with psychosocial problems, but still we need more studies. So for this is, I can see that it's an opportunity for you researchers. We are open for collaboration for the study about this methodology, but also more studies are needed for the prevalence of trauma among street children and their families, because as we were saying, they are just rejected society, communities, families, while they have problems. So we should encourage also family and community-based intervention for organization working in children protection and family promotion. We should also encourage to give access to mental health services in the community, because as my fellow presenters are saying, there are some issues of stigma about if you tell someone to go to the hospital for services, say, oh no, I'm not crazy, so I can't go. But when the things come to them, if I can say in simple words they can understand, they realize that there is a problem, that they need help. We can engage also community in problem-solving skills, because they have that capability instead of bringing solutions, and they give an emphasis on analyzing, educating, and empowering families before any economic support, because they get more support, but they are misused. And also, a very basic needs for children and the families, such as school materials, like shelters, advocacy when it's necessary. Thank you.
Thank you so much, Christine, for a wonderful presentation. I think we have some time for questions. And I think myself and Dr. Elaine, we can start that, I think, with some questions to you before we throw it to the audience. So to Edward, one of the implications you mentioned was strengthen the health system by building health workers' capacity for youth interventions. So can you expound on the best practices for building capacity among health workers who are often overstretched?
Thank you so much. That is a good question. So one of the ways in which we work is systems thinking. Okay, this is where we are trying to leverage on the already existing systems, just integrating certain approaches within the systems. So what happens is that young people in my country are unable to visit these health facilities to ask for such services because, number one, there's issues to do with stigma around mental health. Just mentioning mental health is a stigmatizing issue in my country because it is associated with quite a lot of things. You would find even the same healthcare workers that have not undergone through a training maybe in psychology or these other fields, they don't really understand certain conditions like that because of the so many values and attitudes that are around the communities in regards to mental health. So what we do, we recruit, let's say, adolescent focal point persons, because we are dealing with adolescents, who are in charge of adolescents in reproductive health, because we don't have specific programs for mental health in our facilities. This is something that we are introducing. What we are doing is that we get them, we run them through a values clarification process where they begin to reaffirm their values around mental health conditions that exist in the communities, run them through processes on how to attend to young people, because adolescents is a special group of people. Young people that are still identifying themselves, young people that are still trying to see what they can do about their lives, and they're still going through body changes, and so many things, a process, a phase of confusion. So what we do, we run the healthcare workers through these particular trainings, and then that's when we now do social behavioral change communication in the communities, so they can actually visit these health facilities for such services after they've been made known, after they've been, awareness has been raised to the communities around that. About issues to do with they're already overstretched. They already attend to these young people, but on different other services. It's just like an addition of other services that has not existed. And we are piloting this in 2 districts because there's nothing like mental health care service at primary level in my country. So that's how we are doing it. We're just integrating approaches. Thank you.
Thank you so much for that response, Edward.
Yes, thank you so much, Dr. Edward. So, Dr. Elizabeth, I have a question for you. Mr. Okay, Mr. Edward. Sorry. Dr. Elizabeth, I have a question for you. You said that you are working with Partners in Health team, and I wonder, can you explain how Partners in Health team will replicate your findings and expand your program to other hospitals in Sierra Leone and maybe in other regions? And the second question is, how can researchers, policy makers, and practitioners can work together to support sustainability and replicability within evidence-based programs like yours? Thank you.
Thank you very much. I am working with the Ministry of Health. Partners in Health are like partnering or helping the program I'm running, the unit I'm running. So the unit is basically being funded by Partners in Health and other people because there are different programs we're doing at the same time. So for research, as I said, different research have been done, but it all has been like using models of different countries, like what Russ was saying, like you just estimate. So it was just studies done. Sierra Leone have gone through Ebola, has gone through mudslides, so definitely we've gone through trauma, so this should happen. So one thing I noted while working these 2 years is most of the children we're seeing have neurodevelopmental disorder. So it's a question, is it only trauma or what else are we dealing with in country? So if it comes to research, like we're in a pool or in a well of a lot of data we can play around with. So it's good because now we have the raw data, we have figures, not just estimating, or maybe it should be this. We have the true figures of now it's 270 plus. And Freetown is not Sierra Leone. So that's why I'm thinking of decentralizing, because Freetown is like 3 million to population, and the whole of Sierra Leone is like 8 million. So they are the provinces. And interestingly, in part of this number we have, 20 plus are coming from the provinces, which PIH is helping with transportation. And the neighboring country also, we have people from Guinea that's come for our facilities. So if you're talking about research and policy maker, we have so much we can do. So we're calling on like everybody that is interested that can work with us, because the main motive of me even working with children was to improve in policies. I was looking about going to the parliaments, working in policies, because if you don't change policies, especially with children, you're not improving the health status, you're not improving the mental health status. There are no policies. So, but I can't talk about policy if I don't have data. So that's why I went into to have my data, then I can talk about policy, about how we can approach different issues happening around my country. And sustainability, so that is why I'm involving Sierra Leoneans. All of us working, this is like a work being done purely by Sierra Leoneans. The social workers are Sierra Leoneans. Even the psychologists, the community health workers, they're all Sierra Leonean. Because I think one of the answers I gave him was I had to do with the communication. Because I will just, PIH, the good news, they have training programs. So I will train my staffs, the ones that go to the community, and they will be able to explain to the parents on a lay language, because psychoeducation is very important for these parents. So that's why I'm evolving. It's community-based, it's hospital-based, and it's home intervention. So because I was thinking of a long-term sustainability. So the
running of this hospital, once you have very good capacity building, strengthening them educationally, it may be cheaper than calling in expatriates to be coming in and out. So that was thought of when all of this was in progress. Thank you.
Much.
Thank you so much. The other question goes to Christine. So Christine, from what you have shared, your work and methodology has been so impactful in rehabilitating the street youth. I think it has shown like 70% to be effective. So can you share with us like what methods and how you measured this impact?
Thank you for the question. I have said that we do like a follow-up annually. Because generally we can rehabilitate around 200 children every year. So every year we make a follow-up. When we say follow-up, it's a home visiting for all children we have reintegrated. So we go to their families, we go to their schools. So then you can see if children is at school and at home, and then to go back to school, to the street. If some cases of relapse has happened, then the child can come back for the psychoeducation or psychotherapy if he wants. So I can say this is from our simple tool, like observation and home visiting, but more is needed for the research and having like a scientific study on that.
Thank you so much for sharing that. So I think we have some minutes for questions from audience. I think we can get like 5 questions.
Just go ahead. Hi, could I ask a question?
Yes. Go ahead.
I'm just so impressed with this panel, and actually I've had the pleasure of mentoring both Dr. Alan and Dr. Christine, or she worked with me when we were at Partners in Health in Rwanda, and now Elizabeth. I would really love to work more closely with you in Sierra Leone because you know we work in Sierra Leone. And a theme came up both in your presentation, but especially yours, Christine, and I'd like to hear about your thoughts, Dr. Elizabeth, on substance use issues with young people. In Sierra Leone, we're having this problem of kush. I'm not even really sure what it is. Maybe you can enlighten us and what we're learning about its effects and treatment, and what are the implications, also what we've learned. I'd love to hear from others in your countries about addressing substance use issues in adolescence in particular.
Thank you. Another question? Just note the questions, eh?
My question also goes to Dr. Elizabeth. You talked about the special needs school, and I know your program is new. 2 years is not very long, but considering you have neurodevelopment disorders, I assume you have different spectrums and maybe different levels of intensity. Do you have plans to reintegrate these kids into school so that they're not on their own, because that may also foster discrimination?
Thank you. My question goes to Dr. Elizabeth also. And I was very intrigued by the EEG measurements. We have been trying to do this in Uganda from a community perspective. It has been a challenge. 1, the hardware, 2, the interpretation. So I just wanted to find out, are you using EEG, the traditional EEG, or the AEEG, the amplitude integrated EEG? And how are you doing with the interpretation and the logistics around doing that for all children in schools? Thank you.
Thank you. My name is Marembo Brace. I'm from University of Rwanda. I'm sorry, my question also goes to Dr. Elizabeth. I know, but yeah, according to the number you told us about the status of mental health in Sierra Leone, it seems like the government have abandoned that section. So what is it like your criteria, I mean, the position to address that issue, and what the government thinks about that numbers, and how are you going to challenge in order to improve? Thank you.
One more question.
Thank you very much. My question goes to Christine Sesnda. Thank you for the good program. It's really interesting. So my question is, you said that there are children who drops out of the program. So I'm curious to know what are the factors that lead to that dropout, and what are the strategies Sensidar has set to overcome that dropout. Thank you.
Thank you for your questions. I think we can give a chance to the presenters to respond to those five questions.
Thank you all. Very interesting questions. So I will start up with the substance use disorder. As we know, research has shown that people using substances, it's not because they want to use substances. Research has shown that 80% have underlying mental illnesses. That's for fact. So interestingly, because of time, we have so far in 2 years seen a trend of increased use of substances in teenagers. My youngest will be 7, and it goes way up. So definitely we have the social determinants that's like, it's a must, like maybe or definitely children with take substances, because we have poverty, we have school children be dropped out. And this is like my second research question, and why, the why factor, because we know this is happening, but why is this happening to these children? Is it because of all the traumas we're having? Is it generational? What's really happening? And we notice children are dropping out of school. Are there neurodevelopmental delay? Are there neurodevelopmental disorders? What is happening? So these are all questions we can answer with research. I can't say much. And for the Kush quarantine country, we have like the Sierra Leonean version. So it's been made out of like formalin, acetone, human bones. So it's like they are chemists. So because of that, they go straight into psychosis. And I have so many school-going boys that we have admitted because of substance use. And it's not about peer pressure. We noticed that there had been neurodevelopmental delay. There have been some sort of mental illness. So I was really happy when you spoke about the family intervention, because even I myself, this year in June, I started parenting session, because I noticed there is this big gap. When parents come to the hospital, most of the time it will be caregivers, not the mother, not the father. There's been familial dysfunction. So that's why I was speaking about it. So it's like everything is relating to, it's like a vicious cycle. So it's how we're going to come in, the why factor. And for the special needs school, we didn't have any. And I thought it fit like these children should not stay at home, because going to school helped them with their social ability. So we encourage parents. Yes, we're definitely thinking of decentralizing. And the good news, the government recently gave an act of inclusion where children with disabilities should go to school. Because first, they weren't going to school. Even children with epilepsy will stay home. We had so many children that had seizure, and they had depression, they had anxiety. Because it's either the seizure caused the neurodevelopmental disorder, or the neurodevelopmental disorder caused the seizure. So it's either or, and that's the issues we're facing. So we're thinking of, it all comes back to capacity building, training these teachers. Yes, we have the human resource, people are willing, and even the parents. So that's why we have the parent session, we teach them. And we've got cases, stories, where children that were not able to talk later on because of the parent intervention, children that were not able to write. So the parenting is key. I would say parenting, social support, these are the key pillars when you're talking about childhood development. And talking about the government, so when you're talking about policy, you're talking about the political will, apart from the finances. And
That's why I stick on staying in government as a government worker, and that's why currently I'm also working with the Department of Non-Communicable Disease and Mental Health. So I am like part of the directorate of that. And I'm also working with PIH. So I'm doing a public-private partnership because I think that's the way forward if I want to help children in Sierra Leone. Thank you.
Thank you.
So thank you for the question, Dr. Teresa. For our side, about the substance abuse with children, they use them a lot. So from our experience, when the substance abuse, we know that it's a behavior, so but it's a response to something else. So with children, what we do a lot of psychoeducation. Just the child can come up with just understanding why he or she is using drugs. So because many times cases it can be like psychological distress, it can be like peer pressure, it's a lot. Also they want to be a bit high because they have to face the violence in the street, to find their space among the group. So there are many reasons that they are taking drugs. So then we help them with psychoeducation to know why they are taking drugs. So it means that at the first time, we don't just talk on abandoning drugs. Yeah, so we just talk about the causes of taking drugs, then after they just abandon them. And when we welcome them for the sessions, because we meet them every day from morning to around 4 p.m. So at the beginning, we let them bring their drugs. We don't prevent them from bringing them. They bring them, we keep them. In some cases, there are some who have problems, they want to take them, so we can just give him 2 minutes to take it. Because we observe there's some cases of withdrawing problems, so we have to make sure that he doesn't get problem. So it's a journey of abandoning drugs, but at the end, they abandon them. And we use testimonies from elders who were able to leave drugs and help them to take decision, if I can say. And the problem about the abandonment, if I can say, you know that in mental health, the client has to consent for help. So in this case, for us, the big work is to help children and their families to understand that they have a problem. So this is the big issue. So when we came with that they understand, I have a problem, I need the help, so then in that case, the rehabilitation goes well. So in some cases, children might be not interested, might be not ready to leave his colleagues on the street, might be, because at the street they have some benefits, they get money, they get food, they get everything, they are free from family obligations and everything. So it's about like education. So if he abandons, it's his right, because we don't put them in prison. So, but we tell them that there is a chance, if you want to come back, you can come back. So as long as we work with others, his colleagues can tell, oh, it's fine, you can come, it's good. So some can come back and others cannot. So it's their right. So we don't have any other solution for that. Thank you.
Thank you so much. I think we have time for 2 questions. We can take 2 questions.
Thank you. My name is Nathalie Wamwezi. My question goes to Mushashi Christine. You say that your local government work with street children, and if we look around, we find many children at the street. I want to ask you, how you work with the government, because this is the burden of the government. And I want you to ask what SESDAR do for sustainable impact. How we work with the government to deal with this problem. Thank you.
Thank you.
Thank you. I am Thierry Nawayo from Joy Achievers Foundation. We also work on this issue of street children. But I have a question that goes direct to Christine. We found that street children comes on the street because of different problems, include family issues. There is some children who born from the street parent. There is also children comes on street because they are orphan. But we found that there is child of street and child on street. On the child on the street, we found that there is children who comes on the street because they haven't a parents. So I want to ask you, as is that how do you look after those children, mental health, in a rehabilitation family, even they haven't a parents? Thank you.
Thank you for those questions. I think we can allow the presenters to respond. Yeah, Christian.
So, thank you for the questions. About our working with the government, even if we are a local NGO, but we are under NRS. I think the DG NRS was here in the morning and yesterday, through Ministry of Local Government. So we work with them, we shared with them this methodology and it was approved. For the sustainability, we work with parents and also the local authorities and ISU and community health workers. And recently we are very, if I can say, emphasizing our collaboration with schools, because we know that children spend more of their time at school. So, and it's from school where they can know if the child didn't come to school, if he has a problem, because when you are a teacher, you can see where if the child has a problem. So we train the community, different categories of community volunteers or community people engaged. We are teachers, ISU, local leaders, from the district level to the village level, so that they can understand our philosophy and then they can help in the implementation. So I can say that we work closely with ISU and schools. They are our main actors in this program. So we hope this can assure us that the sustainability can be possible. And for the question about children on the street and the children in the street, so for us, when a child leaves the family and they go to the street, whatever the cause, whatever he did at the street, it's an indicator that there is a problem in the family. So we don't distinguish for those two categories. We take care of them because they are vulnerable children, and then we have an intense work with families that they can be rehabilitated and take care of children. Clearly, we don't have many orphans in those street children. We don't know why. If there are no longer orphans in the country, we don't know. Many of those children comes from like single mother families, like sex workers, like dysfunctional families. So it's those types of families we are dealing with. So, and in some cases, even parents are there. We found out, as long as we work with them, that they're not able to take care of their children. So we look for like grandparents, aunts, uncles, or even the community with what we call Maraika Murinzi. And at the end, when it's not possible, we have a partnership with SOS Children Village through NRS. so then it can be an alternative care for children. Thank you.
So, Dr. Elizabeth.
For the EEG, I'm very sorry, I totally forgot. So because of the residency program and because there was this 90% of our patients having epilepsy, so PIH is fully funding the EEG we have, and the result is being sent directly and interpreted. So purely everything is being run, the logistics, the results, by Partners in Health.
Okay. Thank you so much. I think we are run out of time, and Edward, Dr. Elizabeth, and Christine, thank you so much for sharing your incredible work, and thanks to the audience for your participation. Dr. Ellen, anything to add?
It's, yeah, just to thank everybody, especially especially Dr. Elizabeth, pediatrician, her work, also Mushashi and Edouard. Thank you so much.
Thank you. So we can go.
All right. Okay. That was amazing, wasn't it? Yeah? I can hear some few noise around.
Great. So for the rest of today, all we have left are some pre-recorded lectures, but we want to make it a little bit more dynamic. So first, we're going to close out for the day. We're going to project here on the screen in a moment, once our tech team is back. We'll project the QR code again, if you would please scan and fill out, it's the exact same form as yesterday. We would love to know your thoughts on what's gone well, challenges, practical solutions, and then we'll move forward.
Yeah, and I think this was from the suggestion from yesterday, what you said on your feedback. You said that some of the virtual presentations, we can make it a bit flexible, and I remember me and Libby were saying, oh, so we still have a draft program, so we can update until tomorrow we'll send a final program that we will use. So what we're going to do, we listen to the those. We're going to read out the presentations that are going to happen. If you're interested, please stay here, watch them. They would love to hear your feedback, to hear what you have done. And then concurrently, you can also walk around, visit the exhibition, visit the posters, and if you want, there's also later, once you're getting out, there's a cup of coffee and tea. It's getting cold now in the evenings. Drink a cup of tea. So we won't come back here, but first, we are going to the QR code.
Yes.
Yes, okay.
Perfect.
First one, when you look at the program, those who have it, there's one person called Shema Vincent Remeba. He's from Botswana. He was. We had some technical with his video, so what we will be able to send it later with all the presentations, and you can watch it. But for the sake of acknowledgement, we can. He's an executive director of family and community strengthening trust FACO. He brings in a wealth of experience and qualifications in the field of child/youth education, rehabilitation, and family strengthening, and has really graduated in the narrative therapy, psychosocial support, mental health, community work, and has turned this into her current field of operation. And maybe could you tell us about some
Yes, so Dr. Sam Muhunguzi is a dedicated healthcare management professional from Rwanda, currently pursuing a master's of medical science degree in global health delivery at Harvard Medical School. His interests encompass mental health literacy, equitable healthcare, social justice, and enhancing healthcare service as a whole. Stan's ultimate aspiration is to leverage his expertise and available resources to design and implement programs specifically tailored to address the burden of disease within rural and resource-constrained communities. He strongly believes in the power of customized interventions to lift up these underserved populations.
And that's Dr. Sam. And then Sophia, who was also supposed to be here with us, but you couldn't be able to make it, is a clinical educator at Loma Linda University and works, I think, with Professor Zifon. And in the School of Behavioral Health, she graduated with her doctorate in psychology degree and teaches and conducts research on community resilience model and a biologically based stress management model as well.
And then finally, we have Dr. Zina Kazandar, who is a Palestinian global health researcher who recently graduated from Stanford University with a degree in human biology and concentration in global health. Zina has worked extensively with refugee and migrant mental health communities on literacy and is currently the founding director of Palestine PALS, or Pediatric Research Alliance Leaders, at Stanford University School of Medicine, and is leading the adaptation and scaling of the Youth Readiness Intervention, which we discussed yesterday, to Somali refugee youth in Kenya.
All right. So as you listen to their presentations, write their questions, and then reach out if you have any questions, clarifications, any connections. We can connect you via internet. That's what has been made possible. And I think, have we all scanned the QR code? No? Should they put it again?
Perfect.
So you just have to get your phone, go to Camera or go to Google Scanner. If you go to Google, there's something called Google Scanner, and then you direct it there. That's how we do it. Shall we do it all?
And for those online, I'll drop the link to the form in the live stream because we would still love your feedback as to how the session went from a virtual perspective today as well.
All right, so that's it from any person speaking on the mic. If you see anyone, that's someone sneaking in, that's it for the day. So the rest will be videos, and then our move around, visit and connect as part of the symposium goals. Thank you, Libby, and thank you every facilitator who has been here, who made it amazing right from morning, and it's been a great day.
Yeah, a wonderful day, and we'll see you back here at 8:30 tomorrow for coffee and tea before our final day of sessions.
All right.
Thank you,
Bye-bye.
everyone.
Hi everyone, my name is Zina Khaznadad. I just recently graduated from Stanford University. I wish I could be with all of you today. I appreciate you allowing me to share this presentation via Zoom and share our research. I'll be working with Stanford School of Medicine and the University of Nairobi on this research named Task Sharing and Adapting the Youth Readiness Intervention to War-Affected Somali Youth in Eastleigh, Kenya. So some context on the conflict in Somalia. Somalia faces an ongoing civil war that began in 1991, and the civil war has resulted in over 1 million deaths and serious human rights violations committed especially against children, which has exacerbated the already acute need for mental health services. Some of the human rights violations include sexual violence, exploitation, trafficking, and in 2018, Somalia witnessed the highest number of children recruited into armed forces in the world, with some being, unfortunately, as young as 8 years old. Some 3 million individuals from Somalia have been displaced. Over 50% of these displaced Somali individuals suffer from depression, and it was found that 1 in every 3 Somali refugees suffers from PTSD. Some context of the Somali refugee health context in Kenya. So Kenya hosts one of the largest populations of Somali refugees, hosts 520,000 general refugees with only 100 clinical psychologists to meet the needs of the refugees. So many refugee youth in Kenya have faced highly traumatic incidences, such as sexual exploitation, famine, trafficking. However, there remains a dramatic shortage of mental health providers in Kenya. And many of the refugee youth are particularly vulnerable, facing challenges such as disrupted social networks, struggles to fit in, language barriers, family conflict, and mental health stigmatization, both from the Kenyan community and their ethnic Somali community. Some challenges to Somali youth in Eastleigh. Eastleigh is a neighborhood in Nairobi. It hosts the second largest Somali community outside of Somalia. Somali youth in Eastleigh display very high incidences of psychiatric comorbidity, especially comorbid depression, PTSD. And these urban refugees face overlooked challenges, especially in comparison to those living in refugee camps and rural settings. Contrary to popular belief, urban refugees have actually been found to display similar rates of psychiatric disorders and trauma exposure as those in refugee camps, but are also at higher risk of some additional challenges, including unfamiliarity with the newly resettled environment, discrimination, inability to secure meaningful employment, and urbanization. So to tackle some of these challenges, the Youth Readiness Intervention was developed. The Youth Readiness Intervention is a mental health intervention. It was designed to be delivered by local community health workers, lay health workers, so basically non-specialists. And the intervention aims to meet the unaddressed mental health needs of war-affected youth, as well as build capacity for mental health services and address this shortage of mental health professionals in refugee settings. So some preliminary data, a randomized control trial of the YRI, the Youth Readiness Intervention, was delivered in Sierra Leone to war-affected youth by local Sierra Leonean interventionists. Findings suggested that the YRI was a feasible and acceptable intervention for the war-affected youth, and also showed significant post-intervention effects on emotion regulation, pro-social attitudes, functioning, school enrollment, classroom behavior. And later, this intervention was paired with an employment programming and entrepreneurship programming, and was shown to provide mental health benefits to youth that were high risk of emotional dysregulation and interpersonal deficits. So the specific aims of this study include addressing the shortage of trained mental health professionals in Kenya, and we will do this by this task sharing format, training local community health workers, also to improve child psychosocial distress, demonstrate that the delivery of this intervention can be done with ease from the non-specialists, and also with high level of fidelity or accuracy. Also to build capacity for culturally appropriate community-based mental health care for these Somali refugees in Eastleigh. The intervention will be adapted specifically to this population before any implementation, and also to help youth achieve economic self-sufficiency, positive peer relationships, and community support. So our methodology, as I mentioned, we'll be adapting the YRI using the adapted model, which basically consists of a needs assessment, some individual interviews with experts and key stakeholders, this process called theater testing, which is basically role-playing with the facilitators and with the youth, a mini pre-pilot with kind of a smaller number, smaller sample of youth and facilitators, and also translation of the instruments. The YRI experts from Sierra Leone will be flown to Kenya, and they will be training the local community health workers to deliver this intervention to youth. And in our model, we will be pairing the youth readiness intervention with youth sports and development intervention. So basically, this program is rooted in the CASTLE framework, which is collaborative for academic, social, and emotional learning framework. In this component of the programming, youth will receive sports, yoga, job readiness training. They'll receive multiple certifications. They'll be certified as trauma-informed community coaches. They'll be receiving CPR and first aid training, youth mental health aid training, and professional leadership certifications. And these sessions will integrate transferable job readiness skills and hopefully improve engagement and help destigmatize the mental health services and providing in Eastleigh. And so the model of this method, so YRI experts, like I mentioned, from Sierra Leone will be training community health workers to deliver the YRI. And then YSD, Youth Sports Development Expert, will be also brought in to train local yoga and sports coaches to become facilitators. They will also receive all the certifications mentioned earlier and will be providing sports and yoga, trauma-informed sports and yoga, as well as helping youth also receive their certifications. So sample, we will be recruiting from the Tawakkul Medical Clinic. The Tawakkul Medical Clinic has worked extensively with psychotrauma and serves a large population of Somali refugees in Eastleigh. We'll be enrolling 8 groups of 10 males and 8 groups of 10 females, ages 14 to 15 in one group, in some of the groups, and then 16 to 18 in separate groups. And the YRI will be delivered, which the YRI's format is 12 weekly, 90-minute sessions delivered by gender-matched groups. So our evaluation approach, clinician supervisors, specifically from University of Nairobi and the Tawakkul Medical Clinic, will be in person, supervising all sessions, and they will also be present at the original training of the community health workers. All the sessions will also be recorded, and fidelity checklists will be used to assess fidelity of delivery. We'll also assess child psychological distress compared at baseline, immediately post-intervention, and 6 months post-intervention. And this will be measured by the African Youth Psychosocial Assessment. We'll also have a lot of other measures for secondary outcomes, including the Hopkins Symptom Checklist, the WHO Disability Assessment, measures for anxiety and depression, and we'll be doing qualitative interviews to measure the ease of delivery with the lay health workers and also with the youth. Scaling and sustainability. So we anticipate long-term partnerships with the University of Nairobi, as well as the Tawakkul Medical Clinic. The Youth Sports Development Program was developed and will be continued to be funded by our US partner, Border Youth Tennis Exchange. All facilitators, YSD and YRI facilitators, will hopefully, those that have met competence and have gone through high fidelity and been measured to display high fidelity, will become trainers of the YRI and the YSD, and exceptional youth that have gone through the programs will have the opportunity to be employed and trained as YRI and or YSD facilitators. And we will also be holding dissemination conferences with key stakeholders, and we anticipate the Ministry of Health of Kenya to eventually take over administration of the intervention in order to address their objectives of eliminating shortage of healthcare providers, promoting preventative health, and allowing youth refugees to reintegrate to society as productive citizens in their community. Thank you very much. If you have any questions, please feel free to email me. My email is there below. Also feel free to send me a WhatsApp message if you're interested in hearing more or would like to speak about this project or any other research. So thank you all so much. I hope you have a wonderful rest of the conference.
Hi everyone, my name is Sophia, and in this presentation, we're going to be looking at parents and children's mental health in Sierra Leone. We're particularly interested in looking at their emotion regulation, resilience, and their family dynamics. A little bit about the background in Sierra Leone. We know that parents' mental health plays a central role in shaping their children's mental health, their emotional health and development, and the social health of the children. We know that parents with mental health difficulties, they tend to have more negative parenting behaviors. Hi everyone, my name is Sophia, and in this presentation, we're going to be looking at parents and children's mental health in Sierra Leone. We're particularly interested in looking at their emotion regulation, resilience, and their family dynamics. A little bit about the background in Sierra Leone. We know that parents' mental health plays a central role in shaping their children's mental health, their emotional health and development, and the social health of the children. We know that parents with mental health difficulties, they tend to have more negative parenting behaviors, and research has shown that they tend to be less responsive to the children's needs. So in an environment where poverty, where civil conflict, and even instability is very pervasive, the parental role is even more crucial for supporting their children's mental health. We know that in Sierra Leone, it's interesting that this country faces a disproportionately higher rate of mental health issues when comparing to neighboring countries who are affected by similar traumas. In a 2018 study with about 3,600 adults, this study found that 48% of the participants had symptoms of anxiety and depression, and 76% had symptoms of PTSD. In another 2020 study with Ebola survivors, 25% had anxiety, 47% had symptoms of depression, and 21% had symptoms of PTSD. In the Sierra Leonean culture, research has shown that women face higher rates of mental health concerns compared to men, and this might be due to discrimination, violence, abuse, and just the patriarchal culture and the inequitable rights. In fact, Sierra Leone is the 10th most dangerous country for women. So in this study, we're going to be looking at the baseline rates of mental health of parents and children. And why is our study important? And it's because due to the high rates of mental health challenges in Sierra Leone, the lack of infrastructure in Sierra Leone, considering the fact that there are only 2 psychiatrists for the entire country, considering the impact of intergenerational trauma, and considering the fact that the population of the country is very young, 50% are children, it's important to understand both the protective and risk factors among parents and explore how stress impacts children's mental health within the family environment. So our data was gathered in early 2020 during the height of COVID, and the country was just beginning to go on lockdown. Surveys and consent, they were translated to Creole, and our team recruited a retired university professor to help translate. In the beginning, we interviewed in small groups, but due to the literacy issues, we switched to a one-on-one format. All study personnel were trained in interviewing, research ethics and methods, and we made sure that the content of translating, it was standardized across all measures. Here are some pictures from our survey gathering or information gathering. The measures that we collected, we did DERS for emotion regulation, Connor Davis resiliency scale for resilience. We had the FACES, which is a very long measure, but we used only the cohesion and flexibility subscale. PCL for trauma, Hopkins for anxiety and depression, and the children CBCL for like children and their behaviors and mental health symptoms. All of these measures, the Cronbach's Alpha, are acceptable to excellent, and they have been validated in the African continent. So we have two separate stats analysis. I'll go over the parents first, and then I'll do the children. For the parents, we used SPSS version 28. We first ran descriptive statistics, just looking for general demographic information, and we conducted bivariates correlations looking at anxiety, depression, PTSD, and covariates in order to build the model for multiple linear regression. At the bivariate level, we explored correlations at a p-value of 0.10 or better. And then we ran the multiple linear regression with the significant independent and dependent variables and used standardized significant cutoffs. So for the children's analysis, theoretically, we believe that daily stress impacts the way individuals experience mental health challenges, regardless of family dynamics. So kind of the same process, we conducted correlations in the beginning between anxiety, depression, and externalizing behaviors, as well as covariates in order to build that mediation model. And we use the Hayes process macro on SPSS to run the mediation. You'll see here the demographics of the parents. Their average age was 35, about 80% were female, about 20% were male. 70% of the parents, they were still living together in terms of their marital status. Highest level of education. A good amount of them, 28%, fell into the category of did not complete primary school. And the second highest category, 27.3%, completed some senior or secondary or vocational education. Very, very few completed university level or higher. You'll see in the income, a huge percentage of them, 72%, fell within less than 5 million Sierra Leonean leones. And that 5 million equates to about $250 US. Most of them were Muslim in terms of religious affiliation. And if you look in the CD resilience, a lot of them fell into well, about half fell into the category of they thought their family had low resilience, and about half believed that they had high resilience. They also thought their family was connected or pretty connected in terms of their flexibility. We'll see here that women tend to endorse higher anxiety compared to men. We'll also see that women here endorse more depression when compared to men. And in terms of PTSD, these were the breakdowns within all the categories in terms of risk. You'll see that a huge chunk of them fell into the high risk or very high risk, the high risk category of PTSD. And the same for men, but most of them fell within the medium area. Here is our correlation results. This is some of our demographic variables: resilience, emotion regulation, family cohesion, and flexibility. You'll see that across the emotion regulation, difficulties in emotion regulation is significantly correlated with PTSD, anxiety, and depression. In terms of family cohesion, that's significantly correlated with all three dependent variables as well. Here are the results for the multiple regression. You'll see that our model, gender resiliency, DERS, difficulties in emotion regulation, that is, cohesion and flexibility, that accounts for 27% of the model in PTSD. And the same variables account for 34% of anxiety and 35% of depression. Now, switching gears a little bit, going into the children's demographics, the average age of children were about 11 years old. Most of them tend to be female, or actually, sorry, about half-half, 101 compared to 72 male. They believe that their family was very connected in terms of cohesion, and they also believed their family was flexible or very flexible. Their stress levels, however, were within the clinically significant range, 66% of them. And this was measured by the CBCL. In terms of anxiety, 60% fell within the clinically significant. And in terms of depression, 75% fell within the clinically significant. And lastly, in terms of externalizing behaviors, about half-half, 50 or so fell within the clinically significant, and about 50% fell within normal limits. You'll see here are correlation results. You'll see that gender is correlated with anxiety problems. And stress, the last row, is correlated with anxiety, depression, and externalizing problems. So we use this correlation table to build the mediation model, and based off of our theoretical understanding of stress influencing mental health. Here is our mediation results for the children. You'll see that in terms of family functioning, we grouped cohesion and flexibility together. The higher the cohesion and the flexibility, the lower the stress, and stress mediates the relationship between the family functioning and anxiety, depression, and externalizing behaviors. There is also a direct relationship between family functioning and the three outcome variables: anxiety, depression, and externalizing behaviors. And you'll see that the confidence interval, we know that the mediation model is clinically significant if the confidence interval does not pass 0, which is shown below. So our study's findings are aligned with previous studies. We know that Sierra Leonean parents present with significant mental health challenges, even higher than others, the other studies out there. 76% depression, 81% anxiety, 71% PTSD. Our study also supports that there are gender differences in terms of mental health outcomes. Our study kind of just re-highlighted that women endorse more symptoms when compared to men. And in a very collectivistic culture, family cohesion actually predicted worse mental health outcomes. That was a surprising finding for us. And our hypothesis behind that was, when you share a collective trauma, it can keep the trauma front and center, which may heighten the whole community's experience of anxiety, depression, and PTSD. Another way to think about this is, if you have high cohesion, that might fall into the category of like an unhealthy enmeshment. So like too much cohesion turns into kind of this intermingled enmeshment. And as emotion regulation from our study was significant across the bivariate and the multivariate analysis, It's crucial that individuals can, gain like skills to develop emotion regulation in order for them to better their mental health outcomes. We were also surprised that resilience was not associated with better mental health outcomes. Our hypothesis or our understanding of it is that one can struggle with mental health and still be resilient, and they're not mutually exclusive. In terms of children, our study found, or also we highlighted the fact that mental health challenges can be exacerbated by daily stressors. Some of our limitations, we had a low sample size for the parent group due to convenient sampling and low rates of literacy, which led us to not use kind of like the data collected in the small groups. Rather, we used the one-to-one data. Though we had a low power, we still had prominent patterns across all outcome variables. And while the Cronbach's alpha were acceptable, participants still may have struggled with Western constructs, such as resiliency. And another limitation is that it was a cross-sectional design, thus we can't make causal inferences from our predictor and outcome variables. And lastly, COVID introduced a bias that we couldn't control for. It likely resulted in worse mental health outcomes. And in conclusion, there is just an urgent need for parent interventions that focus on promoting emotion regulation, balancing the family dynamics in terms of cohesion, but still have interventions that support individual autonomy in order to address depression, anxiety, and PTSD. There's also an urgent need for children interventions focused on stress management, and future research should delve deeper into the concept of resilience within this unique culture and context of Sierra Leone. And this calls for a development of a non-stigmatizing, a culturally sensitive and effective mental health intervention that can help build on the existing resilience. So thank you so much for listening to this presentation. I'll be happy to take some questions. Thanks.
Hello, everyone.
Yeah, and in this
As a path to reducing stigma in young adult population. With this study, we're really looking to sort of like see how a mental health literacy curriculum can really sort of like improve the knowledge and understanding of people, as a way to sort of reduce the stigma that is associated with mental health therapy. And we had a hypothesis that mental health promotion / education should be mainstreamed to mitigate the potential growth of stigma in the future. And this was because currently we live in a society where stigma is really sort of like a hindrance to mental health therapy seeking, and people don't feel like free to, seek support, seek therapy for mental health, and that's Hello, everyone. My name is Sam Hanguzi. I'm a student at Harvard Medical School. studying, global health, Master of Medical Sciences in Global Health Delivery. Today I'm going to be talking about the study that I did with my colleague, um, uh, Brooklyn Bradley, who's from Connecticut. We did this study back in 2021, and it's about the analysis of a mental health literacy curriculum and self-care resource database as a path to reducing stigma in young adult population. With this study, we're really looking to sort of like see how a mental health literacy curriculum can really sort of like improve the knowledge and understanding of people, as a way to sort of reduce the stigma that is associated with, mental health therapy. And we had a hypothesis that mental health promotion / education should be mainstreamed to mitigate the potential growth of stigma in the future. And this was because currently we live in a society where stigma is really sort of like a hindrance to mental health therapy seeking, and people don't feel like free to, seek support, seek therapy for mental health. And that's a huge problem. And with this research, we were aiming at analyzing a mental health literacy curriculum and self-care resource database, as a remedy, or maybe as sort of like this solution to this, to end this issue, this stigma chain that is associated with mental health therapy in communities like Rwanda and many other sub-Saharan African countries. Um, you know, really in this project we did evaluation of mental health implementation, mental health literacy, curriculum implementation and school systems. Like, looked at different places where this is sort of like already a reality, like where this is being practiced. And we also looked at the impact that this has had in terms of changing the narrative and the sphere of mental health, and how people really look at mental health issues and how they seek support, and the sort of like the general understanding of this sort of problem, and this whole subject of mental health. And because this study was done in the middle of the pandemic, COVID-19, 2021, we wanted to also look at the effects that COVID-19 has had in ramping up mental health issues. And in especially in the adolescents and younger adult population. And we have slides that talks about that as well. For methodology, we mainly did qualitative research and a lot of secondary analysis of the already existing data. And here we did it through academic journals, peer-reviewed journals, and scholarly journals and articles that really talks about mental health and mental health education and awareness, and how different studies talk about this sort of like paradigm. We also did an interview with the school counselor, who also happens to be a clinical psychologist. She's done a lot of counseling for university students across different universities in Kigali. And she shared some insights and sort of like the current status of mental health seeking, and in the university students, and sort of like the young adults population, how they understand this whole mental health paradigm, and how they're sort of like taking measures to ensure that they stay mentally healthy and aware. For content analysis, we first of all wanted to look at the prevalence of mental health in Rwanda. And as you can see, anxiety is predominantly, sort of prevalent in it, in Rwanda. And this is according to the study that was done in 2014. And depression is, also up there with 15.3%, and then PTSD, which is second sort of like biggest in percentage. And, we looked at a study that was done in Rwanda. One of the studies that we really looked at throughout this study, shows that out of 367 children and adolescents aged 10 to 17 years, 71.9% report the presence of depression-like symptoms. And it's really through studies like this that you get to see how big of a conundrum that mental health is. And this is just not numbers. It just speaks to how much and how big this whole mental health issue is. And if you have like children that are really struggling with depression, and we still have like stigma in the society, like we don't have any like free spaces, like safe havens for just people to be able to talk about their issues and their struggles on a daily basis. That's already a challenge that needs to be sort of looked at and solved. um, looking at different studies that were done on, developing a mental health literacy curriculum and what impacted sort of like it's hard in those countries, and the countries or maybe in the places and areas where this is already like being practiced. And we here, in this case, we looked at Canada, Ottawa, where a study that was conducted in 24 high schools on 534 students. The researchers discovered that the outcome of having like a classroom-based resource, maybe curriculum, um, was really positive, because it sort of like improved the living conditions of the people that were sort of like previously dealing with mental health issues, and especially young people, high school students, and basically adolescents and young adults. And this way the demographic for the study. And it sort of highlights how the education and awareness that was raised through these resources and classroom-based courses really sort of like revolutionized the healthcare space, the mental health care space, and health in general. Because one mental health is one component of healthcare as a whole. And if you take it out of the equation, then you don't have a full healthcare. So we did look at different other sort of like prevalent and effects of mental health disorders. And um you know and this included lack of motivation and extreme sadness, suicidal tendencies, and depression. These are all sort of like the effects that come with poor mental health. And which also derives from lack of knowledge and education, and leads to obviously stigma. People, one, not being able to seek support because there's no safe space to begin with for people to be able to seek the support that they need and the care. So it's just hard, and it just leads to all these issues that are being talked about. And with COVID-19, it sort of exacerbated mental health issues due to limited, socializing that was going on during COVID-19. There was no, you know, gathering and social events and stuff like that. And this really sort of like took a toll on, young people's mental health. And, it also sort of like caused a lot of other issues like financial constraints And this wasn't just on the youth or maybe the adolescents and the young adults. It was also on the parents and adults who were sort of like having a hard time sustaining their families financially, and that also sort of contributed a lot on the mental health issues that people dealt with throughout the COVID era. In the one of the points that were highlighted by the clinical psychologist, the school counselor that we talked to, she highlighted that many people, students that come to seek care to that she talks to actually in different events that are organized by the school, by these institutions, is that she hears a lot of you know you know sort of like ignorance, but also like sort of like you know the things that are sort of like hindering these young people to really seek support because they don't feel comfortable, one, telling their stories and sharing their feelings, even though she's a professional and they know that um, she's just there for that, but they still like feel uncomfortable to share their stories with us, a stranger. That's how they call it. So, and it's really a big challenge because this is somebody that is trained to sort of like take care of these issues, and the students that the demographic that is disproportionately affected according to many studies that actually were conducted on mental health and prevalence of mental health in Rwanda, and the demographics that is affected mostly is the adolescents and the young adult population, and so, and they still like don't have um, sort of like the courage to go out there and seek support. And this speaks on how much, that needs to be done in terms of educating them on how and why to, seek care for mental health. In conclusion, this study really, looked a lot in different sort of like the impacts and different mental health literacy curriculum that were implemented in different places, and different other resources and interventions that were sort of like put in place to solve this problem of stigma that is associated with mental health care seeking and stuff like that. And really the only sustainable way to sort of increase mental health literacy, and which also leads to having people seek support that they need on a daily basis, is through developing a school, maybe a classroom based course or resources. And in this case we're talking about curriculum, which is a great way to sort of like sustainably solve this issue, and educate a generation that can really know when to seek support and how to seek support whenever they need it. And it can also be able to advocate and teach others on how to really deal with these issues going forward. Thank you for your kind attention and questions. Welcome.